Yeah, so hello everyone, good evening. Myself Dr. Omkar Sangita Dilipra Sononi, and today I welcome you all back again to the session of Sparks. And today we'll be discussing the very important subject, that is ophthalmology. Okay, so we will be actually revising ophthalmology in a retrograde fashion. All the AFMG regular batch students know that they have attempted ophthalmology test yesterday. I hope all of you, the regular batch students, have attempted it, and those who are not regular batch students, don't worry. We'll go together. Okay, we'll solve these questions and then revise these in a retrograde fashion. Okay, easy. So please remember, guys, these questions are mainly focused from the previous FMG examinations. Okay, these questions have been asked in previous year FMG exams. Whereas nowadays ophthalmology is a bit more clinical. They are asking more clinically oriented question. So for that purpose, we'll be coming up with a clinical case discussion for ophthalmology also, as well as other clinical subjects in an integrated fashion together. So about CCD, I'll be informing you very soon. For that, in the meanwhile, let's discuss about the test that was conducted yesterday. So without any further delay, guys, let's move on. So the first question, guys, that we had yesterday was about esotropia is most commonly associated with. Okay, so now let's discuss it. First of all, what do we mean by esotropia, all the aspects about esotropia. Okay, so just discussing it in a nutshell. So first of all, what do we mean by squint or strabismus? So please remember, guys, squint or strabismus means deviation of your eye. Okay, so deviation of your eye to any of the sides is considered squint or strabismus. Okay, there can be multiple types of squint. So the one of the types of squint is your manifest squint. Okay, one of the type of squint is your manifest squint, and it is also known as tropia. Okay, it is also known as tropia. So if we are looking forward, okay, both of our eyes are in forward direction, then it is known as isotropia. Then it would be known as isotropia, right? But if both of the eyes are deviated inwards, then it would be known as esotropia or a convergent squint. Esotropia or a convergent squint. Whereas if both the eyeballs are deviated outwards, then it is known as exotropia or a divergent squint. It is known as exotropia or divergent squint, right? If both of them are upwards, it would be known as hypertropia, and if both of them are downwards, it is known as hypotropia, right? Easy to understand. So please remember the most important ones being, if both of the eyes are deviated inwards, then it is known as esotropia or convergent squint, and outwards it is known as exotropia or divergent squint. So now here we'll be talking about esotropia, that is about convergent squint. Okay, esotropia can be of two types. It is accommodative as well as non-accommodative. So what happens actually, to have a clear vision, the eye tries to accommodate. Okay, the eye tries to accommodate, and during that esotropia is there. Okay, esotropia can be seen during accommodation, and this is known as your accommodative esotropia. Accommodative esotropia is further subdivided into refractive and non-refractive. So what do we mean by this? So please remember, refractive accommodative esotropia would be associated with hypermetropia. That is, in hypermetropes we usually can see refractive accommodative esotropia, whereas non-refractive accommodative esotropia, it is usually seen when there is high AC by A ratio. Just understand this, okay guys, high AC by A ratio. Okay, then what is the treatment usually preferred in cases of refractive accommodative esotropia? So as we know that they are associated with hypermetropia. So as we all know that hypermetropia is usually treated with what kind of glasses? So please remember, hypermetropia is usually treated with convex glass. Okay, so please remember, hypermetropia is treated with convex glass. On the other hand, myopia is treated with concave glass, right? Hypermetropia, convex glass; myopia, concave glass. Okay, so please remember this. Whereas the third important thing that you need to remember is astigmatism, and astigmatism is treated with cylindrical glasses. Okay, astigmatism is treated with cylindrical glasses. This was a question previously asked. Next, in cases of non-refractive accommodative esotropia, as I've already told you, it is associated with high AC by A ratio. The treatment which is there It is usually bifocal glasses. Okay, so please remember, bifocal glasses means those glasses which can be used for both, that is for near as well as for distance vision. Those are known as your bifocal glasses. Okay, last is a non-accommodative esotropia, and in non-accommodative esotropia actually there is no known cause, that is it is idiopathic. There is no known cause, that it is idiopathic. Okay, it is present from the birth itself, therefore it is known as actually essential or congenital esotropia. It is present from birth, therefore it is known as either essential or congenital esotropia, right? And what is the treatment usually in these cases? Okay, in these cases usually the treatment would be surgeries. Okay, usually we treat with surgery. And the most important, squint surgeries, guys. Okay, for most of the squint we perform surgeries, and for surgeries you need to remember two important ones. First is your recession surgery. And what do we mean by recession surgery? We actually loosen the muscles. Okay, we actually loosen the muscles. This is known as recession surgery. And the next type is resection surgery. Here we actually cut the muscles to make them strong. Okay, here we cut out the muscles to make them strong. These are known as resection surgeries. So recession and resection surgeries are used to treat squint. Okay, easy. Now just going back to our question, esotropia is most commonly associated with, as you all know now, esotropia is most commonly associated with option A, that is hyperopia. Guys, I expect answers in the chat box. Please be very much active. Okay, so the discussion would be more fruitful for you guys. Okay, because the things you answer are easily remembered. Okay, I hope that you answer now. Moving on to our next question, guys, and that says, which among them is a prerequisite or a predisposing factor, you can say, for development of sympathetic ophthalmitis? Okay, so which of this is a risk factor for sympathetic ophthalmitis? And the options are penetrating ocular trauma, blunt ocular trauma, chemical injury, and infection. So please type your answers in your chat box, so it would be easier for me to know. Then in the meanwhile, till you answer, we'll actually discuss some important points about sympathetic ophthalmitis. Okay, so please remember, guys, this is an important topic. What do we mean by sympathetic ophthalmitis? So please remember, sympathetic ophthalmitis is nothing but a bilateral granulomatous panuveitis. Okay, as we all know, eyeball has how many layers? Eyeball has 3 layers, right? The outermost is your sclera and cornea, whereas the middle one is your uvea, and the innermost is your retina, right? And the middle layer, that is your vascular coat, which is known as uvea, it is composed of, first is your ciliary body and second is your choroid. Okay, so what happens when all the uvea is inflamed? Okay, the anterior as well as the posterior uvea is inflamed, that is known as panuveitis, right? And this is a granulomatous condition that if we perform a histopathology, we can find granulomas. We have already discussed about granulomas earlier, right? So please remember, sympathetic ophthalmitis is nothing else but a bilateral granulomatous panuveitis. So now, first of all, what is the dangerous area of the eye? So please remember, the danger area of eye is your ciliary body. This question has been asked, guys, previously. So please remember, the danger area of eye is your ciliary body, because if there is some trauma, there is some infection in the ciliary body, it can spread to the whole choroid or to the whole eyeball itself. Okay, so please remember, dangerous area of your eye is your ciliary body. Okay, and what is the main cause of sympathetic ophthalmitis? Yes, all of you are right. Please remember, it is your penetrating injuries. Please remember, it is your penetrating injuries to the eyeball that lead to this sympathetic ophthalmitis. Okay, penetrating injury to your eyeball leads to sympathetic ophthalmitis. Please remember this. Okay, now what are the important signs? So please remember, what happens as the ciliary body is injured, as we all know, so there is loss of accommodation. As we all know, the important function of ciliary body is what? Accommodation. So as ciliary body is injured, there would be loss of accommodation, there would be decrease in near vision. And what would be the sign? Signs are very much important for this. So please remember, the earliest sign, okay, important one, the earliest sign in cases of sympathetic ophthalmitis which appears is retrolental flare. Okay, what we can see? It is retrolental flare. What do we mean by ophthalmitis? Itis means it is inflammation, right? Inflammation of your eyeball. So wherever there is inflammation, there would be infiltration of your cells, right? And as these cells infiltrate in your eye, what happens? These cells actually appear like a flare, okay? And these are behind your lens, therefore they are known as retrolental flare, okay? These are known as retrolental flare, which is the earliest sign of sympathetic ophthalmitis. Important. And one more important sign that you need to remember, guys, is your Dahlen-Fuchs nodules, okay? So please remember, Dahlen-Fuchs nodules are usually seen in choroid in cases of sympathetic ophthalmitis. This question was asked in NEET PG and it can be asked in your exam too. So please remember, Dahlen-Fuchs nodules are seen in cases of sympathetic ophthalmitis. Moving further, what is the treatment? So please remember, in cases of sympathetic ophthalmitis, usually the treatment are steroids. Usually the treatment are what? They are steroids. But as a prophylactic measure, what we can do? As a prophylactic measure, we usually perform enucleation. What do? We perform enucleation, okay? What is enucleation? That is removal of your eyeball, okay? So please remember, we remove the eyeball, okay? So please remember, there is enucleation of the affected eye. The affected eye is removed because, as you all know, if there is injury to one eye, okay, then it can spread to another eye and it can lead to bilateral panuveitis. Both the eyes would be affected. So to prevent this spread to another eye, we actually remove the affected eye. That is, enucleation of the affected globe is done as a prophylactic measure in cases of sympathetic ophthalmitis. I hope this is very much clear now. So going back to our question. So guys, what was our answer? Which among them is a prerequisite for the development of sympathetic ophthalmitis? Most of you are right. So please remember, it is option A, that is penetrating ocular trauma, usually at the level of ciliary body, which is the most dangerous area of eye, right? Moving further, guys, to our third question that says characteristic finding of a fungal ulcer is, and the options are satellite lesions, feathery ulcer with hypopyon, dendritic ulcer, and ring abscess. So your answers please in the chat box. Till that time, we'll be discussing about your fungal keratitis or fungal corneal ulcer. Okay, so please remember, keratitis is what? Kerat means your cornea, itis means again inflammation. So it is your inflammation of the cornea, okay? Inflammation of cornea known as keratitis. There can be various etiologies of keratitis. There can be viral, bacterial, fungal, okay, amoebic. There can be different types of keratitis, and this keratitis can further progress to a ulcer, okay? It can further progress to a ulcer, right? So now we'll be discussing about fungal corneal ulcer. What is the important point? So please remember, okay, usually in cases of keratitis or ulcers, what happens? There is an epithelial defect, okay? As we all know, the corneal epithelium is injured or there is some defect. There is necrosis, that is what which leads to the ulcer. Along with that, as there is inflammation, there would always be infiltration, right? So please remember, usually in cases of fungal ulcers or any of the ulcers, there would be epithelial defect along with necrosis and along with infiltration, right? Which is the most common fungi? Any one of you? So please type in the chat box, which is the most common fungi responsible for causing fungal corneal ulcer? Please tell me. In the meanwhile, I'll be discussing the cause. And what is the cause for fungal corneal ulcer? It is a history of trauma with some vegetative material, okay? So if any plant material or any of the grass material, that is your vegetative material, it goes into your eyes, it causes trauma. That is responsible for causing any fungal keratitis or fungal corneal ulcer, okay? That is the main cause. Any one of you can just tell me which is the most common fungi responsible for corneal ulcers, okay? In the meanwhile, I'll be telling you about signs, okay? Where are the symptoms? So please remember a very important point in fungal corneal ulcers, that signs are more predominant as compared to the symptoms, okay? The patient would not experience much of symptoms, but the signs would be more predominant, okay? The patient would come to you with some minor signs, minor symptoms, but you will notice like majority of signs in this patient, okay? So signs are more predominant. So which are the most important signs? Very good guys. Please remember aspergillus, okay? So please remember, the most common fungi responsible for causing fungal corneal ulcer is your aspergillus. It is your aspergillus, right? Now moving further to our signs. So which are the important signs of fungal ulcer that you need to remember? First of all, you can see the image over here, okay? I have included some images over here. So in this image, what you can see? You can see a ulcer which is almost ring shaped, right? So please remember, it is a dry ring shaped ulcer, okay? It is a dry ring shaped ulcer, along with what are the margins, how you can see the margins, these are feathery margins, right? So along with feathery margins. So please remember, it is a dry ring shaped ulcer with feathery margins. Okay, this is important. Okay, then next one, you can also see hypopyon. Okay, this is a ring shaped corneal ulcer with this feathery margins. Okay, and over here what you can see at the base of the cornea, you can see hypopyon. Okay, what do we mean by hypopyon? So please remember, hypopyon means pus in the anterior chamber. Okay, so please remember, you need to remember two important definitions. Hypopyon is pus in the anterior chamber, pyo. Okay, and hyphemia, amia means blood, that is blood in anterior chamber, which is usually seen in cases of anterior uveitis, right? Hypopyon in cases of corneal ulcers and hyphemia in cases of anterior uveitis. Okay, remember this. So the hypopyon is very much important, guys, in cases of fungal and bacterial ulcers. You can differentiate fungal and bacterial ulcers depending on this hypopyon. Usually in cases of bacterial ulcers, this hypopyon is mobile. It keeps on moving here and there. The pus is mobile. Okay, it is liquidy and it is sterile. Okay, it is sterile. It does not contain any bacterial element. Whereas in cases of fungal keratitis, what happens, this hypopyon is fixed. Okay, it is fixed and it is unsterile, that is, it contains fungal hyphae. Okay, it contains fungal hyphae, therefore it is unsterile and it is fixed at one place. Okay, important one. Next one, you can also see a ring. Okay, the deposition of immune complexes. Okay, immune complexes are your antigen antibody complexes. So deposition of your immune complexes can lead to a formation of ring known as immunological ring of Weasley. Okay, please remember, it is known as immunological ring of Weasley. Okay, important one. If you can see over here, it is immunological ring of Weasley. This is very much important, guys. So what are the important signs that you remember? Dry ring shaped corneal ulcer with feathery margins. Second, a fixed and unsterile hypopyon. And third, deposition of immune complex leading to immunological ring of Weasley. Now we come to the most characteristic sign, and the most characteristic sign, usually this is your ulcer and the fungal hyphae actually they are scattered around the ulcer. Okay, they are scattered around the ulcer, they keep on moving around the ulcer. Okay, and these look like satellites around a planet, therefore these are known as your satellite lesions. Okay, therefore these are known as your satellite lesions. So please remember, guys, satellite lesions are the most characteristic sign in cases of fungal corneal ulcer or fungal keratitis. Okay, please remember this. And now, what is the drug of choice? Usually for treatment we prefer eye drops, right? We prefer topical drugs. And in cases of fungal corneal ulcer, what is the drug of choice? It is your 5% natamycin drop. We prefer an antifungal agent, that is natamycin. Okay, so please remember, we prefer 5% natamycin eye drops. Okay, good to go. Now moving back to our question, characteristic finding of fungal ulcer is, yes, most of you are right. So please remember, it is option A, that is satellite lesions. Please remember, guys, don't confuse. Feathery ulcer with hypopyon is also seen in cases of fungal ulcer, but it is not the most characteristic finding. They have been asking about the characteristic finding. Okay, this is the difference, guys. Okay, important ones. Whereas dendritic ulcers, it is usually seen in cases of viral keratitis, that we will be discussing further. Okay, then moving ahead, guys, with our fourth question, which states, what is the term given to a condition with an extra layer of cilia posterior to the gray line? Okay, so extra layer of cilia, what it is known as? So just type your answers in the chat box. Just type your answers in the chat box, guys. What an extra layer of cilia is known as? So I'll start with option A, that states tylosis. Okay, that is your tylosis. So please remember, guys, tylosis is nothing but thickening of your eyelashes or thickening of your cilia. Okay, so please remember, tylosis is nothing but thickening of your cilia or eyelashes is known as tylosis. Moving on to our next option, that is madarosis. So please remember, this is your madarosis. Okay, so what you can see over here, so please remember, there is lateral loss of eyebrows. Okay, so please remember, what is madarosis? There is lateral loss of eyebrows. Okay, so please remember, madarosis is usually seen in cases of leprosy. Okay, so madarosis is lateral loss of eyebrows, which is usually seen. Moving further to our next one, option C, that is dystichiasis. Okay, option C, that is dystichiasis, and all of you are right. Very good. Answer is option C, that is dystichiasis. over here you can see there is an extra layer of cilia posterior to the gray line, okay, which is known as this trichiasis. Okay, here you can see extra hairs, okay, extra hairline can be seen, extra cilia line can be seen, okay. And last is your trichiasis. And what do we mean by trichiasis? So please remember, by trichiasis we mean this. And what we can see over here, we can see misdirected cilia. So please remember, cilia in various direction, okay, eyelashes in various direction, inward, outward, above, downwards, okay, all this is known as trichiasis, which you can see over here, okay. This is known as your trichiasis, which is usually seen in cases of anterior uveitis, right, which is usually associated with it. I hope all of these findings are very much clear to you now, okay. Now moving forward to our next question, and that is the movement of Livo elevation will be lost in, okay, Livo elevation. I'll draw for you over here, okay. So if this is your left side, this is what do we mean by Livo elevation. So just tell me your answers. The movement of Livo elevation will be lost in cases of, okay. In the meanwhile, we'll be discussing about your innervation of your extraocular muscles. As we all know, there are various extraocular muscles and they are mainly innervated by the third, fourth and the sixth cranial nerve. This we are sure about. Now let's see which are the innervations of your third cranial nerve, also known as your oculomotor nerve, right? So third cranial nerve or oculomotor nerve, it innervates first of all your levator palpebrae superioris, also known as your LPS muscle, which helps in elevation of the eyelid. And if this elevation of eyelid does not happen, if there is LPS palsy, it can lead to ptosis, okay. If LPS palsy occurs, it can lead to ptosis, that is drooping of eyelids, right? Next one is your superior rectus. Third cranial nerve also innervates your superior rectus muscle, okay, which causes elevation of the eyeball, which helps in elevation of the eyeball. Next is your inferior rectus muscle, which helps in depression of the eyeball, right? Next is your medial rectus muscle, which helps in adduction of the eyeball. What do we mean by adduction? Adding to the body, means inward movement, right? That is adduction of the eyeball. And last is your inferior oblique, okay, inferior oblique muscle. It usually helps in what? Inferior oblique muscle usually helps in elevation. So please remember, recti नाम के हिसाब से जाता है. Superior rectus will help in elevation, but oblique is ulta. Inferior helps in elevation and superior helps in depression, okay. This, remember this, important. And next one is your sphincter pupillae muscle, okay, which is a pupillary muscle. And sphincter pupillae muscle, it usually helps in causing constriction of the pupil, that is meiosis, okay. It usually helps in causing meiosis. So third cranial nerve usually innervates what? Levator palpebrae superioris, superior, inferior, medial rectus, inferior oblique and sphincter pupillae. Now there is a mnemonic, Shivani ma'am would have given you this, okay, and that states LR6SO4, okay. What do we mean by this? LR means your lateral rectus muscle is innervated by the sixth cranial nerve, that is your abducens nerve, that is your abducens nerve, whereas the superior oblique muscle is innervated by your fourth cranial nerve, that is your trochlear nerve, okay. So please remember, these are the only two exceptions, otherwise all the extraocular muscles are innervated by your third cranial nerve, that is oculomotor nerve. So what is your answer, guys? Yes, very good. Please remember, now mainly in this what has happened, okay, so elevation is affected, okay, and elevation is a primary function of which muscle? It is a primary function of your superior rectus muscle, okay, superior rectus muscle. And it is usually affected in cases of superior rectus palsy, that is due to option B, third cranial nerve palsy or oculomotor nerve palsy, right? Moving further to our next one, I hope this is very much clear. Just move, before moving ahead, I want you guys to remember this fact, that if there is abducens palsy, okay, if there is cranial nerve sixth palsy, so what would happen? Okay, abducens palsy would lead to lateral rectus palsy, okay, and lateral rectus palsy agar hogi, so abduction would not happen, right? Abduction or outward movement of eyes would not happen, right? And the patient usually experiences diplopia, that is double vision, and there would be ipsilateral head posture. If right eye is affected, the patient would turn his head towards right, okay. This would be the posture he would attain for himself, okay. So please remember, there would be a ipsilateral head posture or head turn which would be seen. Whereas in cases of trochlear nerve palsy or fourth cranial nerve palsy, the superior oblique muscle would be affected, okay. It would undergo paralysis, and in this case again there would be diplopia, that is again double vision on looking downwards, okay. Diplopia on down gazing would be seen, and there would be a contralateral head posture. What do we mean by contralateral head posture? That is, if the right eye is affected, the patient would turn the head towards the left side. Okay, this is your contralateral head posture, which the patient usually attains in cases of trochlear nerve palsy, right? Moving further, guys, to our next one, that states, question 6, excessive administration of which vitamin causes macular edema and cyst? So your answers and the options are vitamin A, vitamin B, vitamin E and niacin. So please tell me your answers, guys. Excessive administration of which vitamin usually causes macular edema and cyst? What is macula actually? Macula is the central part of the retina. So if this is your retina, the central part of your retina is known as your macula, right? And macula is responsible for what? Yes, macula is responsible for your central vision, also known as tunnel vision. Okay, so please remember this, macula is responsible for central vision, and if there is macular edema, there would be blurring of the central vision. Okay, blurring of central vision would be seen. So now just tell me, excessive administration, you are close, guys, but I want a specific answer. Please remember, guys, no, you are confusing. So please remember, excessive administration of option D, that is niacin. Yes, very good, guys, that is vitamin B3. What is niacin? Niacin is your vitamin B3. Excessive administration of niacin usually leads to macular edema and cyst. Okay, so niacin is usually used in which condition? So please remember, it is a lipid lowering agent. As we all know, it is a lipid lowering agent used in cases of hypertriglyceridemia. Okay, so it is a lipid lowering agent. Okay, so niacin, if used for a long period of time, okay, chronic use of niacin would increase the levels of niacin in the body. Okay, chronic use of niacin would increase the levels of niacin in the body, which can further lead to macular edema and cyst. Okay, there would be extravasation of fluid, edema ho jayega. Okay, extravasation of fluid around the macula, and which will cause blurring of vision. Okay, so please remember, usually the patient who is on niacin therapy, if he is presenting to you with blurring of vision, it is mostly due to niacin, which has caused macular edema or cyst. Okay, I hope this is very much clear. Important point, most of you were confused with vitamin A, guys. So please remember, guys, vitamin A deficiency is more important than excess. Okay, so vitamin A deficiency, usually seen in cases of malnutrition, this vitamin A deficiency can lead to xerophthalmia. Okay, it can lead to xerophthalmia, which we'll be discussing in in upcoming questions. So please remember, vitamin A deficiency causes xerophthalmia, whereas vitamin A excess is also known as hypervitaminosis A, and hypervitaminosis A can also lead to blurring of vision and dimness of vision. Okay, but it cannot lead to macular edema and cyst. Macular edema and cyst are characteristically seen with niacin excess. Okay, moving further to our next one, guys, and that states, what is the diagnosis of a patient with unilateral proptosis? Okay, what is proptosis? So proptosis is protrusion of the eyeball. आँख बाहर निकल आती है थोड़ी. Okay, there is unilateral proptosis on one side. There is bilateral sixth nerve palsy, that is abducens nerve palsy is there, along with chemosis. Okay, redness vagara is seen, and there is a euthyroid status. Why they are specifically mentioned euthyroid status? Because as we all know, proptosis or protrusion of eyeball is commonly seen in cases of thyroid ophthalmopathy, right? It is usually seen in cases of thyroid ophthalmopathy. But thyroid ophthalmopathy, it can be seen in hyper, hypo or euthyroidism also, right? But they have made it clear somewhat. Okay, and what is the answer, guys? Yes, most of you are right. It is option A, cavernous sinus thrombosis. Okay, why does it point towards it? So let's discuss it now. So please remember, guys, usually what do we mean by cavernous sinus thrombosis? What is cavernous sinus? Cavernous sinus is the biggest vein in which all the facial veins drain. Okay, it is biggest vein at the base of the brain in which all these facial veins drain. Right, so any of the facial pathologies, it can be a nasal furuncle, okay, it can be sinusitis, maxillary or ethmoidal sinusitis, that can spread via these cavernous sinus. Okay, okay, and there can be infection which can spread via these cavernous sinus to the brain, and it can lead to cavernous sinus thrombosis. Okay, so usually if cavernous sinus thrombosis occurs, what happens is this image. Why I have included this image? So please, over here you can see at the base of the brain, what is this? This is your cavernous sinus, the one I have marked with red. Okay, so this is your cavernous sinus, and in relation to cavernous sinus, what we can see in closest relation to cavernous sinus is this nerve, that is our Okay, that is our what? That is our sixth cranial nerve, also known as your abducens nerve. That is our sixth cranial nerve, known as abducens nerve. Right, so it is in the closest relation. So the first thing affected, or the first structure affected in cavernous sinus thrombosis would be your sixth cranial nerve or abducens nerve. It would undergo palsy. Okay, the lateral rectus muscle would be paralyzed in cases of cavernous sinus thrombosis. Along with that, in lateral relation to cavernous sinus, what we can see? We can see the third cranial nerve, that is our oculomotor nerve, the fourth cranial nerve, that is our trochlear nerve, and also the first and second branches of your fifth cranial nerve, that is ophthalmic and maxillary branches of your trigeminal nerve. All of these are in lateral relation to your cavernous sinus, but the first nerve affected, if they ask, that is abducens nerve or your sixth cranial nerve. Okay, and then your third, fourth and fifth cranial nerves would be affected. As third and fourth cranial nerves are also affected, it can lead to further ophthalmoplegia, that is most of the muscles of your most of the extraocular muscles would be paralyzed, and that leads to ophthalmoplegia in cases of cavernous sinus thrombosis. Okay, and as there is involvement of these ophthalmic and maxillary branches, okay, so please remember, as there is involvement of this ophthalmic and maxillary branches, what happens is there would be what? There would be maxillary flushing. Over here you can see maxillary flushing and periorbital swelling can be seen. Okay, I hope these things are clear to you. First of all, sixth cranial nerve palsy leading to lateral rectus palsy, then there would be involvement of third and fourth cranial nerve leading to ophthalmoplegia, and lastly involvement of first and second branches of trigeminal nerve leading to facial flushing and periorbital swelling. Okay, and as there is cavernous sinus thrombosis, it pushes the eye forward, that causes this proptosis. Okay, important thing. I hope you are fine with it now. Let's move further, guys, to our next one, and that is shifting fluid sign is seen in. Okay, so shifting fluid sign is seen in which of the following? That is exudative retinal detachment, tractional retinal detachment, rhegmatogenous retinal detachment, or retinitis pigmentosa. And your answers, please in the chat box type your answers. In the meanwhile, we'll be discussing important points about the retinal detachment, which is a very important topic. First of all, we'll start our discussion with exudative retinal detachment. By the term exudative, what we mean? So please remember, exudative is either associated with some infection, with some inflammation, or with some malignancies or tumors. Okay, that we mean by exudative, right? So exudative retinal detachment, it is due to what? So what happens in retinal detachment actually? So the 9 layers, that is your neurosensory retina. Retina is usually made up of 10 layers. Okay, 9 layers make up the neurosensory retina, and the last layer is retinal pigment epithelium, which is the 10th layer. Okay, in between this, if there is extravasation of fluid, okay, both of these layers are separated. Okay, both of these layers would be separated, and that causes the detachment. Okay, right? So this is your retinal detachment, which is usually seen. So what happens in ERD, exudative retinal detachment? In this case, there is the sodium potassium ATPase pump which is there. Okay, there is sodium potassium ATPase pump on your retinal pigment epithelium. On this retinal pigment epithelium, there is a sodium potassium ATPase pump, okay, which usually keeps the retina dehydrated. इसका main function क्या होता है? To keep retina dehydrated. Okay, to avoid blurring of vision, to keep retina dehydrated. But if this pump now fails, then what happens? The fluid will go inside. Okay, the fluid will go inside the retina, leading to detachment, and this is known as your exudative retinal detachment. Okay, and this pump usually fails. What are the causes of exudative retinal detachment? As I've already told you, the main important causes would be any of the tumors or malignancies, conditions like eclampsia, where there is excessively high blood pressure, then malignant hypertension, again where there is excessively high blood pressure, and conditions like sympathetic ophthalmitis, which we have already discussed. In these conditions, like inflammatory conditions, hypertensive conditions, or tumors, usually exudative retinal detachment is seen. Okay, what are the important symptoms which are seen? So please remember, the important symptoms which are seen are floaters. Due to accumulation of that fluid, there can be floaters, there can be flashes, okay, and there would be sudden but painless loss of vision. So please remember, there is sudden but painless loss of vision. This is very much important, guys, to remember where it is painful and where it is painless loss of vision. Okay, so there is sudden painless loss of vision. Okay, important thing. And what is the important sign seen in cases of ERD? The important sign seen in cases of exudative retinal detachment is what? It is your shifting fluid sign. Okay, it is your shifting fluid sign. Okay, so please remember the shifting fluid sign is usually seen in cases of ERD, right? Now let's discuss about next one, that is RRD, that is our rhegmatogenous retinal detachment. Usually RRD or rhegmatogenous retinal detachment, it is due to a tear in your neurosensory retina. Okay, the 9 layers of retina, they have got some tear, and that has lead to a detachment from your retinal pigment epithelium. Okay, so a tear in neurosensory retina can lead to rhegmatogenous retinal detachment. And which is the important sign seen in cases of RRD? So please remember, it is your Schaffer's sign which is usually seen. Okay, the Schaffer's sign which is usually seen in cases of RRD. Okay, so what do we mean by Schaffer's sign? In Schaffer's sign, actually there are vitreous pigments which are causing the dimness in vision. So please remember, in Schaffer's sign seen in cases of RRD, the vitreous pigments which have been accumulated, these are causing issues, or these are causing dimness of vision. Right, and the last one is our tractional retinal detachment, and this is the most important one. TRD or tractional retinal detachment, please remember guys, it is due to a traction. Okay, it is usually due to a traction or pull which is there on the retina, and it can be seen in cases like where there is new vessel formation or new angiogenesis, like in cases of proliferative diabetic retinopathy, in cases of central retinal venous occlusion, or in cases of Ehlers disease. Please remember guys, Ehlers disease is very much important, where there is recurrent vitreous hemorrhages usually seen in young adult males. Okay, how do we define Ehlers disease? Recurrent vitreal hemorrhages seen usually in cases of young adult males. It is important to be remembered, right? So I hope now this can be easily remembered. Okay, so now let's yeah, the answer all of you are right over here. Option A, that is exudative retinal detachment, ERD, is usually seen in it can show us the shifting fluid sign. It can show us the shifting fluid sign. Floaters are usually seen where there is fluid. Okay, so please remember, if there are cells in the fluid, there would be inflammation, there would be cells infiltration in this. Okay, and these cells can actually lead to this floaters. Okay, so please remember this. Now moving further to our 9th question guys, that is, which layer of cornea helps in maintaining hydration of the stroma of cornea? So now this is a very easy question, I hope. Now it is related to the anatomy of cornea, and before moving on to the actual question, let's discuss the important points about anatomy of cornea, which is very much important. Questions have been asked, and I hope you can answer this question easily. But just before that, we'll be discussing important points about the anatomy of cornea. Usually the cornea contains how many layers? So please remember, cornea is what? So first of all, cornea, it is the 1/5 portion of the outermost layer of your eyeball. Okay, outermost layer of eyeball is made up of sclera and cornea. Sclera makes up the 4/5 part, and 1/5 anterior most part is made up by cornea, which is a transparent avascular structure. So it is usually made up of 6 layers, and the important 6 layers that you need to remember, first one is your epithelium, the corneal epithelium. It is made up of 5 to 6 layers. Okay, there are 5 to 6 layers of these corneal epithelium, and they contain stem cells. Okay, stem cells honge matlab kya? These are pluripotent cells. They will keep on regenerating. Okay, whenever there is a defect, it would be repaired by itself. Okay, due to the presence of these stem cells. Okay, so regeneration is seen in cases of corneal epithelium. Second is your Bowman's membrane. Second is your Bowman's membrane. Okay, and Bowman's membrane is actually a pseudo layer. Okay, it is not considered a true layer, it is a pseudo layer. Why do we call it a pseudo layer? Because it is acellular, it does not contain any cell. So how do we differentiate it from another layer? So please remember, it is just the thickened part of the stroma. Okay, so thickened part of stroma is known as your Bowman's membrane, which is not considered a true layer because it does not contain any cell. The third important layer of cornea is your stroma. Okay, so please remember, stroma is the most important part because it is the thickest part of your cornea. So please remember, more than 90% of corneal thickness, is made up by this corneal stroma. Next one is your Dua's layer, and Dua's layer, it is named after Dr. Harminder Dua, who actually found it out. So Dua's layer is named after Dr. Harminder Dua, and one important point to be remembered is it is the most resistant layer. It is the most resistant layer. Next one in line guys is your Descemet's membrane, and the most important layer is this one. Okay, this and endothelium are the two most important things that you need to remember. बाकी सब भूल जाओ चलेगा, Descemet's membrane and endothelium बिल्कुल नहीं भूलना है. Okay, so what do we mean by Descemet's membrane? So please remember, Descemet's membrane is a resistant layer. It is not the most resistant, but it is a resistant layer. An important thing to be remembered is what? In Descemet's membrane, usually what happens, there is deposition of copper in copper excess condition. Which is that copper excess condition? It is Wilson's disease. So usually in cases of Wilson's disease, whenever there is copper excess, this copper gets deposited in this Descemet's membrane, leading to a formation of a ring known as Kayser-Fleischer ring. Okay, the KF ring usually seen in Wilson's disease, it is due to deposition of copper in this Descemet's membrane of cornea. This question have been asked, you need to remember this. And the last layer of cornea is your endothelium, which is the most important layer. Okay, metabolically also it is the most important layer. So please remember, the most important layer of cornea metabolically is your endothelium. It is the most important layer of your cornea. So important one. Why it is the most important layer? First thing, it contains the sodium potassium ATPase pump. Okay, it also contains the sodium potassium ATPase pump, which helps in keeping the cornea dehydrated. Okay, and as the cornea is dehydrated, there would not be any blurring of vision, right? So please remember, it contains the sodium potassium ATPase pump, helping in dehydration of cornea. Second, it contains important endothelial cells. Okay, and these endothelial cells, the count can be asked. Okay, normal endothelial cell count कितना होता है? So please remember, the normal endothelial cell count is approximately 2500. Okay, it is usually 2500 cells per square millimeter. Okay, it is usually 2500 cells per square millimeter. If this cell count goes below 500 cells, then it leads to corneal opacity. Okay, so please remember, normal endothelial cell count is how much? 2500 cells per square kilometer. If this endothelial count goes below 500 cells per square kilometer, it would lead to corneal opacity. It would lead to corneal opacity because the dehydration of the cornea would not be maintained. Right, I hope I am clear now, and yes, all of you are right. The answer over here is option B, endothelium. It helps in maintaining hydration of the stroma of cornea, and it keeps the cornea dehydrated with the help of the sodium potassium ATPase pump. जितना fluid चाहिए उतना ही रहता है बस cornea में फिर. Okay, moving further to our next one, guys, and that says lesion producing incongruous homonymous hemianopia with Wernicke's pupil is seen in. So please remember, guys, this question is very much important from neuro-ophthalmology, and I hope all of you were able to answer this. So before you answer this, let's move on to this one. First of all, okay, all of you might be well aware of the optic pathway, right? The optic pathway which starts with the retina, the photoreceptors of your retina, that is your rods and cones, which are your first order neurons. Important ones, please remember, rods and cones, that is your photoreceptors, are your first order neurons. From there it starts to your bipolar neurons, then to your ganglion cell layers, and then it moves ahead, right? Then, so important thing over here is your optic nerve. First of all, you need to see at various parts, whenever there is a lesion, it would manifest differently. Okay, so please remember, whenever there is a lesion at your optic nerve, जब भी optic nerve पे कोई lesion होगा, there would be what? There would be anopia. Okay, please remember, optic nerve lesion would lead to anopia. Means what? Complete loss of vision in that particular eye would be there. Okay, complete loss of vision would be there. So please remember, optic nerve lesion would lead to anopia. Important one. Next one, guys, that is optic chiasma. Optic chiasma is the place where actually crossing occurs. Okay, crossing of the nasal fibers usually occurs. Okay, crossing of the nasal fibers occur at the optic chiasma. And usually, as we all know, one famous question which has been always asked, pituitary gland is in close relation with this optic chiasma. So whenever there is some pituitary adenoma or a prolactinoma, it can compress this optic chiasma and can lead to what? So please remember, any optic chiasma lesion can lead to what? So please remember, optic chiasma lesions usually leads to a heteronymous hemianopia. Okay, and let's see first of all the difference between heteronymous and homonymous hemianopia. Okay, so what we can see over here, homonymous hemianopia, इसका मतलब क्या है? Same side. Okay, both the left sides are affected in this. Okay, both left sides are affected in this, that is homonymous hemianopia. And what do we mean by heteronymous hemianopia? Heteronymous means both the temporal sides are affected, means one side, the left side is affected, other side the right side is affected. So please remember, if the sites are different, it is known as heteronymous hemianopia. If the sites are same, it is known as homonymous hemianopia. Right, till here I am clear, I feel so. Okay, so if there is any optic chiasma lesion, any lesion at the optic chiasma, it will lead to heteronymous hemianopia, the second one. Okay, the second picture. And as the nasal fibers are affected over here, okay, the pituitary gland would actually cause the compression of your nasal fibers at the optic chiasma, right? And as we all know, there is cross innervation in the eye. Okay, nasal side controls temporal side and temporal side controls nasal side, right? So as there is nasal fiber compression, it would lead to temporal hemianopia, and both sides it was known as bitemporal hemianopia, right? So it is heteronymous bitemporal hemianopia, usually seen in cases of lesions to the optic chiasma due to pituitary adenoma or prolactinomas. This is very much important, guys. Question mein usually aayega, a patient presents to you with galactorrhea. Okay, so please remember, usually these signs are usually seen with prolactinomas, which is one of the most common types of pituitary adenomas. Okay, ऐसा कुछ case तुम्हारे पास present करेगा, right? So remember this. Then next one is your optic tract. If there is any lesion of your optic tract, it would lead to what now? It would lead to homonymous hemianopia. Same side का effect होगा. Okay, it would lead to homonymous hemianopia. Left to left, right to right, right? So optic tract is made up of what? It is made up of your lateral geniculate body, your optic radiations till your visual cortex, right? So any lesions in the lateral geniculate body, optic radiation of visual cortex, it can lead to homonymous hemianopia. And if there is solely lesion at the visual cortex, or isolated lesion at the visual cortex, can lead to what? It can lead to quadrantanopia. Quadrant, एक quadrant effect होगा. Okay, quadrantanopia. What do we mean by quadrantanopia? So this, okay, one quadrant would be affected. This is quadrantanopia, and along with quadrantanopia we can see macular sparing. As we all know, macula is the central part of the retina, so the macula would not be affected. Okay, macula would not be affected. There would be macular sparing seen in cases of visual cortex lesions, right? I hope I am very much clear till over here. This is very important to understand, guys. Optic nerve lesion, anopia, complete loss. Optic chiasma lesion, heteronymous bitemporal hemianopia if central part is affected. Optic tract lesion, homonymous hemianopia. Visual cortex lesions, quadrantanopia along with macular sparing. Now just remember some important abnormal pupils. Okay, so there are some conditions where the pupils are abnormal, either constricted or dilated, that you need to remember. Okay, and the important pupils that you need to remember, first one is your Wernicke's hemianopic pupil. Okay, so hemianopia to hai hi already. Along with that, you can see a typical Wernicke's pupil. What is this Wernicke's pupil? It is usually seen in cases of optic tract lesions. So please remember, Wernicke's hemianopic pupil is usually seen in cases of optic optic tract lesions. Just a minute, guys. Now moving further to our next one, that is Argyll-Robertson pupil. So Argyll-Robertson pupil में क्या होता है? Usually the light reflex is present. Okay, the light reflex is lost, but the accommodation reflex is present. What happens in Argyll-Robertson pupil? The light reflex is lost, but the accommodation reflex is present. Okay, accommodation reflex is still present. Okay, this is your Argyll-Robertson pupil, which is also known as prostitute's pupil. Why do we know it as prostitute's pupil? Because it is seen in a condition known as syphilis, which is sexually transmitted. Okay, so it is usually seen in prostitutes. Therefore, Argyll-Robertson pupil is also known as prostitute's pupil, where the light reflex is lost but accommodation reflex is intact. Okay, next one is your Marcus Gunn pupil. What is Marcus Gunn pupil? It is your relative afferent pupillary defect. Okay, RAPD. Okay, it is usually seen in cases of incomplete or early optic nerve defect. Whenever there is incomplete or early optic nerve defect, we can see relative afferent pupillary defect known as Marcus Gunn pupil. And if there is total afferent pupillary defect, this total afferent pupillary defect is usually known as amyorotic pupil, which is seen in total or chronic optic nerve defect. It is usually seen in total or chronic optic nerve defect. I hope these things are clear now. Wernicke's hemianopic pupil in cases of optic tract lesions. Argyll-Robertson pupil in cases of syphilis. Okay, also known as prostitute's pupil. Marcus Gunn pupil, also known as RAPD, usually seen in incomplete or early optic nerve defect. Amyorotic pupil known as TAPD, usually seen in total or chronic optic nerve defect. Right? Now just moving back to our question, region producing incongruous homonymous hemianopia with Wernicke's pupil is due to what? It is due to region to your optic tract. So please remember, it is due to region to your optic tract. I hope now it is very much clear. Moving further guys to our next one, and that states evisceration is removal of which layer of eyeball? Evisceration is removal of which layer of eyeball? Now any answers to this? Evisceration. So we have two important terms, that is evisceration and enucleation. So what do we mean by this? So first of all, we'll study about enucleation. Enucleation was performed where? We studied it already, right? It was performed in cases of sympathetic ophthalmitis to prevent the spread to normal eye. Okay, enucleation of affected eye was done. And what I told you there, removal of the globe. Okay, so please remember, removal of eyeball totally is known as your enucleation. Removal of eyeball is known as enucleation. Okay, we do not remove any orbital content. Please remember guys, the orbital bones, the orbital muscles are left intact. Okay, we don't touch them, we just remove all the layers of your eyeball. The eyeball is totally removed, and that is known as enucleation. Okay, पूरा का पूरा nucleus निकाल देंगे ऐसा. Okay, so please remember that is enucleation. Whereas what do we mean by evisceration? Viscera is removed. Okay, so viscera means the most important parts are removed. Viscera is what? The most important parts. And what are the most important parts of your eyeball? Those are your vascular layer, that is your middle layer, and the neural layer, that is your innermost layer, that is retina. So please remember, the uvea and the retina are removed, that is middle and the inner layers of eyeball if removed, that is known as evisceration. If total eyeball is removed, that is known as enucleation, right? So the answer to this question would be very right. It is option A, middle and inner layers of eyeball is removed. Moving to our next question guys, question number 12, which states, which among the following is not used, okay? Please focus on these words every time you come across such a question. Not used for color vision testing. Okay, क्या हो जाता है यूजुअली, हमने देखा कि विच ऑफ द फॉलोइंग टेस्ट इज यूज्ड फॉर कलर विजन टेस्टिंग. जल्दी जल्दी में पहला देखा, अच्छा इशिहारा पता है, इशिहारा मार्क करके निकल आए. ओके, दीज आर द यूजुअल थिंग्स वेयर वी टेंड टू मेक मिस्टेक्स. ओके, सो प्लीज रिमेंबर दिस. नाउ color vision tests are what? So please remember different color vision tests. Please tell me the answer for this question guys. What are the different color vision tests? First is your Ishihara test, which is very commonly used. Okay, Ishihara test. But problem with Ishihara test क्या है? It only tests your red and green color blindness. Okay, if you have red and green color blindness, it is tested only by Ishihara test, not other colors. Okay, so Ishihara test. Second is your Holmgren wool test. Okay, second is your Holmgren wool test. And third most important is your Fm100U test. Fm100U test. Okay, so please remember what is most important to be remembered about Fm100U test, that it is the most sensitive color vision test. Okay, so please remember, if the question is asked which is the most sensitive color vision test, the answer should be Farnsworth Munsell 100U test or Fm100U test. Okay, important one. Okay, whereas the other test can be your anomaloscope or lantern test. Okay, these are also your color vision test. So now just before moving further, you just need to remember color blindness के बारे में एक question बार बार पूछा जाता है. You all would be knowing what is green color blindness, red color blindness. Just remember the definitions. But one question which has been commonly repeated from pathology also and from ophthalmology also, it is about the pattern of inheritance. Which is the pattern of inheritance of color blindness? So please remember, color blindness is usually inherited by X-linked recessive pattern of inheritance. It is usually inherited by X-linked recessive pattern. Okay, X-linked recessive pattern. That means it is more common in males as compared to females. Okay, it is more common in males as compared to females. Okay, important one. So the answer to this question now, which test is missing? Option C, Ames test. So please remember, Ames test is not a color vision test. Okay, moving further guys to this one. So please remember, these are the two most important tests at least. इनके image तो तुम्हें पता होने चाहिए. These can be asked in the examination. This क्या दिख रहा है? बस red and green is seen, right? So it is your Ishihara test. What is this? Only red and green seen, that is your Ishihara test. यहाँ पे क्या दिख रहा है? Almost 100 colors दिख रहे हैं. So the next test is what? This one is your Fm100U test. Okay, it is your Fm100U test. right? So most important charts that you need to remember, the images from color vision tests. Moving further to our next question, guys, that states drug which is contraindicated in cases of keratitis. I have already explained what is keratitis, inflammation of the cornea. So which drug is contraindicated in cases of keratitis? Options are A, teardrops, option B, cycloplegics, option C, steroids, and option D, timolol. So any answers for this question? So just type your answer in the chat box, guys. So now, usually what happens in cases of inflammation or keratitis, we need to soothe the eyes, okay? We need to give a relief to the eyes. Therefore, teardrops are usually indicated, right? Teardrops hum likhte hai usually to just soothe your eyes. Next is your timolol. Timolol is a beta blocker. It is a topical beta blocker, which is usually used in form of eye drops, right? And timolol is usually used to decrease your intraocular pressure, which might be raised in cases of some inflammatory conditions, okay? Whereas then the two options left with us are option B, cycloplegics, and option C, steroids. So please remember, cycloplegia. What do we mean by cycloplegia? It means paralysis or relaxation of your ciliary muscles. So please remember, what do we mean by cycloplegia? Cycloplegia means relaxation of your ciliary muscles. So what happens usually in cases of inflammation, in cases of infection or inflammation, the ciliary muscle undergoes spasm, and जैसे ही ciliary muscle spasm में जाते हैं, that leads to excessive pain. Okay, so the excessive pain, it is due to ciliary muscle spasm. Okay, ciliary muscle spasm leads to excessive pain, and to relieve this pain, we need to give cycloplegic agents, which would cause relaxation of these ciliary muscles. And what are these cycloplegic agents? These are atropine, homatropine like drugs, cyclopentolate, okay? All of these drugs are cycloplegics. Therefore, these are also indicated. So the answer over here is option C, that is steroids. So please remember, guys, steroids are usually contraindicated in cases of keratitis. They are relatively contraindicated because the problem being these are immunosuppressive agents. At times what happens, they can worsen the infections, okay? At times steroids can worsen infections. Mainly fungal ulcers or viral ulcers are usually worsened with cases of of steroids, okay? So please remember, this is one thing, that they can either worsen the condition, and second thing, they can lead to perforation of the corneal epithelium. They can cause perforation of the corneal epithelium. Because of these two important reasons, steroids are absolutely contraindicated in cases of keratitis, relatively contraindicated. Moving further to our next question, the 14th one, which states, which among the following is seen in retinitis pigmentosa? Retinitis pigmentosa. Okay, which of the following is seen? Option A, arteriolar attenuation. Option B, neovascularization. Option C, microaneurysm. Option D, papilledema. So let's discuss few points about retinitis pigmentosa, which is a very important topic again. So what happens actually in retinitis pigmentosa? There is idiopathic degeneration of your retina. Idiopathic means there is no known cause. Okay, कोई cause पता नहीं हमें why it happens, but there is idiopathic degeneration of rods and cones. So please remember, the photoreceptors of your retina, that is rods and cones, both of them, they undergo degeneration, okay? But there is no known cause. Idiopathic degeneration of rods and cones. If asked which are commonly degenerated, then please remember the answer should be rods. Rods are commonly degenerated, okay? R for rods, R for RP. I hope this helps you, okay? So rods ज़्यादा degenerate होते हैं as compared to cones, okay? So please remember, because they are more in number also, okay? So idiopathic degeneration of rods and cones is actually retinitis pigmentosa, which is more commonly seen in young males, okay? So the case would present with mostly a 25-year-old young male, okay? The case would start with like this something. So now the modes of inheritance, the question have been asked on this. What are the modes of inheritance seen in cases of retinitis pigmentosa? So please remember, retinitis pigmentosa shows all modes of inheritance, but the most common mode of inheritance shown is autosomal recessive. So please remember, retinitis pigmentosa is inherited by all modes, but the most common mode which is seen is your autosomal recessive pattern of inheritance. Important one. Next one is your symptoms. What are usually the symptoms seen? Usually the symptoms would be vision loss, right? If the rods and cones are degenerating, definitely the day as well as the night vision, or the color as well as the dim vision would be lost. So there would be vision loss along with a tunnel vision which is left, okay? Okay, tunnel vision is only left. So tunnel vision is due to what? It is due to macula. So please remember, usually macula is spared in early stages of this disease. Okay, macula is usually spared in early stages of disease. Therefore, there can be only tunnel vision which is left. Okay, peripheral vision would be affected. So there is vision loss and tunnel vision. Along with that, the most important part is your signs. And ma'am would have given you a mnemonic known as BAP. And what do we mean by BAP? B goes for bony spicules. Okay, B goes for your bony spicules. Okay, these are your bony spicules which can be seen over here, right? These are bony spicules. Second, A goes for your arteriolar attenuation. So what do we mean? Thinning of your blood vessels, thinning of your retinal blood vessels is known as arteriolar attenuation. Over here you can see these thinned out blood vessels. Okay, so these are attenuated arterioles. Okay, so arteriolar attenuation. And lastly, what you can see, the optic disc over here. Okay, ये जो optic disc दिख रही है, just pardon me for your time. Yeah, the optic disc over here is pale. Okay, so there is a pale disc. So please remember, BAP is the mnemonic for remembering the signs of retinitis pigmentosa. B for bony spicules, A for arteriolar attenuation, and P for pale disc. Okay. So what do we use usually for diagnosis? So for diagnosis of retinitis pigmentosa, we usually prefer electroretinography. Usually retinitis pigmentosa is a degenerative condition which cannot be reversed. Okay, which cannot be reversed. It cannot be treated properly. But to just prevent this condition, we can just give a prophylaxis. Okay, we can adopt a preventive measure, and that can be our vitamin A. Okay, so it is just adopted as a preventive measure or a prophylactic measure to not let retinitis pigmentosa progress, but it cannot stop it completely, right? So now what is the answer? Why there is still so much of confusion, guys? So please remember, the answer over here should be option A. Arteriolar attenuation is seen in cases of retinitis pigmentosa. Okay, about other things we'll be discussing in the upcoming questions. Moving further to our next one, that states the first sign of sympathetic ophthalmitis. And now I expect your answer. BAP. Okay, BAP is B for bony spicules, A for arteriolar attenuation, and P for pale disc, pale optic disc. So please answer for this question, guys. Question number 15. First sign of sympathetic ophthalmitis. We have already discussed sympathetic ophthalmitis. Options are A, circumcorneal congestion, option B, retrolental flare, option C, hypopyon, and option D, iris nodules. Very good. Others? Very good. The answer over here is option B, that is retrolental flare. I have already told you the earliest sign or the first sign seen in cases of sympathetic ophthalmitis is your retrolental flare due to presence of cells behind your lens. Okay, so please remember there would be retrolental flare. Very good, guys. Moving further to our next question, that states, which is very much important now, all of the following are incorrect statements. Okay, all of the following are incorrect statements regarding lens induced glaucoma except. So all are incorrect except one, that is we need to find the correct statement or the true statement. Okay, so before moving on to the actual discussion of this, let's understand what is this, the lens induced glaucoma. Okay, so first of all, we'll be discussing about lens induced glaucoma. So what is glaucoma? Glaucoma is characterized by three things. First, increased intraocular pressure. Okay, and this increased intraocular pressure is due to what? Increased intraocular pressure is due to blockage of this aqueous humor. Okay, the aqueous humor cannot drain properly. Okay, the aqueous outflow is blocked, and aqueous outflow is via the trabecular meshwork or the uveoscleral pathway. Okay, any of these pathways, if blocked, they can lead to increased intraocular pressure due to elevated aqueous humor in the anterior chamber. Okay, first is your increased intraocular pressure. Second is your optic nerve defect. Second thing should be optic nerve defect, and the third thing should be visual field defect. Okay, so the visual field should also be defective. These three things together characterize glaucoma. So what do we mean by lens induced glaucoma? Lens की वजह से होने वाला glaucoma. So let's see. Lens की basic pathology क्या है? Usual pathology of lens. The commonest pathology of lens is what? Cataract, right? So there can be something associated with cataract, right? So now let's discuss what it is. So first of all, as we all know, cataract usually progresses in various stages, from lamellar separation to hypermature cataract. The second stage being this incipient cataract. Second stage of cataract is what? Incipient cataract. So what happens usually in incipient cataract? We can see phacomorphic glaucoma. I'll explain you this by the name itself. Okay, so please remember, you just remember this. In cases of incipient cataract, we can see phacomorphic glaucoma. Okay, so phaco means lens and morphic means due to the morphology, because of the structure there is glaucoma. So why due to the structure of lens there is glaucoma? So please remember, in cases of incipient cataract, the lens capsule is thickened. Okay, there is a thickened lens capsule along with the lens swelling. Okay, the lens imbibe water. Okay, lens imbibe water inside it, and that causes lens swelling. So this lens swelling and the thickened lens capsule can increase lens in size, and as the lens is increased in size, okay, it can, if it grows anteriorly, it can block your trabecular outflow, right? And if the trabecular meshwork or the outflow is blocked, then aqueous humor would increase in the anterior chamber, leading to increased intraocular pressure, finally leading to glaucoma, right? So this is how incipient cataract can lead to a phacomorphic glaucoma due to the structure of the lens, right? I hope this is very much clear now. Second is your hypermature cataract, which is the last stage of cataract. Okay, it further progresses to mature cataracts. Okay, immature cataract, then your mature cataract, then your hypermature cataract. So hypermature cataract can be of two types. If the lens cortex is liquefied, okay, if this is your lens, usually lens is a gelatinous crystalline material, right? Lens contains crystalline material. If this lens cortex is liquefied, pani bhar jata hai andar pura, okay, it is liquefied, then it is known as a Morganian cataract. And if this lens shrinks in size, then it is known as a sclerotic. Due to fibrosis, the lens would shrink in size. This is known as sclerotic cataract. But in cases of sclerotic cataract, what happens? Lens is held by what? It is held by zonules, okay, suspensory ligaments or zonules. Okay, so these zonules would become lax, ढीले पड़ जाएंगे. Okay, they would become lax. Okay, these are the two important things you need to remember. Now let's see how glaucoma is seen. So in cases of Morganian cataract, what happens actually? So there is liquefaction of the cortex, and also the lens capsule is deteriorated. The lens capsule is damaged, and as this lens capsule would be damaged, these lens proteins or the lens material would be coming out. Okay, it would be leaked out. Okay, and as these lens proteins are leaked out, these proteins would go and then block the trabecular meshwork. Okay, it would go and block the trabecular meshwork, again obstructing the aqueous outflow, leading to increased IOP, leading to glaucoma, right? So this type of glaucoma would be known as phacolytic glaucoma. Now I'll explain by the name itself. Okay, नाम से याद रखना है बस. Phaco means lens, lytic means damage of lens. So यहाँ पे क्या हो रहा है? Damage of lens leading to leakage of lens proteins, leading to blockage of aqueous outflow, leading to phacolytic glaucoma seen in cases of Morganian cataract. Whereas in cases of sclerotic cataract, what is happening? Lens is shrunken in size, the zonules are becoming lax, and जैसे ही zonules lax हो जाएंगे, क्या हो जाएगा? Control छूट जाएगा lens के ऊपर का, and the lens can move here and there. Okay, and this if this lens moves here and there, then it can lead to subluxation of the lens. There can be subluxation or dislocation of the lens, and subluxation or dislocation of the lens can lead to what? It can lead to phacotopic glaucoma. Topic means position. So please remember, lens की position अगर गलत हो जाए, then it can lead to phacotopic glaucoma. Okay, if the lens is dislocated anteriorly and it blocks the aqueous outflow, again leading to obstruction, again leading to increased IOP. I hope these things are clear to you. Now let's move back to our question and let's see one by one what are the statements. First is option A, phacomorphic glaucoma is an open angle glaucoma. We have seen already. Okay, so please remember, the glaucomas which we have seen already, all of them are mostly angle closure glaucoma. They were obstructing the angle, right? So all of them were mainly angle closure glaucomas. Open angle glaucomas which are lens induced, they can be the anaphylactic glaucomas. Okay, lens anaphylactic glaucomas or lens antigene glaucomas can also be seen. Those are open angle glaucomas. Whereas phacomorphic glaucoma is a angle closure glaucoma, therefore this is a wrong statement. Second, in phacolytic glaucoma, lens capsule is intact. Phacolytic, lysis हो रहा है, Morganian cataract, what happens? Lens capsule breaks down, right, and therefore leakage occurs. Therefore lens capsule is not intact. This statement is wrong. Next, option C, phacomorphic glaucoma has a deep anterior chamber. As we all know, if it is moving inwards, okay, if the lens is growing in size, it is actually making the anterior chamber what? It is making the anterior chamber shallower. So it is not a deep, rather it is a shallow anterior chamber. This is also a wrong statement. Last is mature cataract is an example of phacolytic glaucoma. So please remember guys, yes, mature or hypermature cataract may usually we can see phacolytic glaucomas. Okay, in mature cataract also you can see at times phacolytic glaucoma, right? Option D. Okay, moving further guys, I hope things are clear to you now. Moving further to our next question, that states, question number 17, drug of choice in eye in trachoma endemic areas. So they are basically asking what is the drug of choice for trachoma. So just answer in the chat box. Before that, I will be moving on to trachoma, which is very much important from ophtha as well as from PSM point of view. So please remember, trachoma is also known as Egyptian ophthalmia. It is also known as Egyptian ophthalmia. Okay, it is usually seen in tropical countries like Egypt. Okay, it is also known as Egyptian ophthalmia. In that, what happens, there is chronic inflammation. Okay, there is chronic inflammation of your cornea as well as conjunctiva. Chronic inflammation of cornea and conjunctiva is known as trachoma. Okay, usually seen in tropical countries. What is the basic etiology? The organism which leads to trachoma is what? It is your Chlamydia trachomatis. Naam mein ye uske, okay, Chlamydia trachomatis. But there are important points to be remembered about Chlamydia trachomatis. Which serovars of Chlamydia trachomatis can cause trachoma? Which are the serovars? So please remember, serovar A to C are responsible for causing trachoma. Okay, so serovars A to C of Chlamydia trachomatis can lead to trachoma. Serovar D to K, okay, serovar D to K can lead to ophthalmia neonatorum, and they can also lead to paratrachoma, also known as swimming pool blindness. Okay, so please remember, serovar D to K of Chlamydia trachomatis can cause ophthalmia neonatorum or paratrachoma, also known as swimming pool blindness. And lastly, the L serovar, it is important from derma point of view. The L serovar of Chlamydia trachomatis can lead to LGV, that is lymphogranuloma venerum, right? Bubo wala suna hoga to, right? This is the one that you need to know about Chlamydia trachomatis. Now coming to the actual clinical features, so let's go by the images. Okay, so first of all, what you can see over here, you can see some papillae, right? So please remember, what you can see over here, you can see some papillae, and these papillae are giving what kind of appearance? These papillae are giving velvety appearance. So please remember, usually papillae give a velvety appearance to the palpebra. They give a velvety appearance to the palpebra. Okay, important one. Next, in this image, what you can see, the image A, here you can see some follicles, right? These are some follicles, but these follicles resemble what? These follicles are resembling sago grain. Sabudana suna hoga, right? So these follicles are resembling sago grain. So please remember, these follicles resemble sago grain. They give a sago grain appearance. Okay, sabudana jaisa dikhta hai. Okay, next, the image C, it shows you what? So please remember, here you can see some scarred lines. Okay, and these scarred lines are due to what? These are due to this follicles which have now been scarred. Okay, so now these scarred follicles will give you these scarred lines known as what? These scarred lines are known as Art's lines. Okay, so please remember, these are known as Art's lines. Okay, these are known as Art's lines, important. And the next image shows you what? The last one, first of all, this shows you some opacity. Okay, this is your corneal opacity known as pannus. Okay, this is your corneal opacity known as pannus, important one. Okay, this is corneal opacity. Okay, important one. And these are your misdirected cilia. Trichiasis bola tha na maine. So please remember, misdirected cilia or trichiasis is also seen in cases of trachoma. Okay, I hope now these things are clear to you. Now, moving further to our WHO classification. Just the name, which is the WHO classification for trachoma, it is your Fisto classification. So please remember, Fisto classification is the classification given by WHO for trachoma. Important one is this, the WHO strategy for trachoma, question from PSM, very important. Which is the WHO strategy for trachoma? It is your safe strategy. Okay, safe strategy. What do we mean by safe strategy? S goes for, okay, we can usually treat trachoma by these means. First of all, S goes for surgery, A goes for drugs like antibiotics, F goes for facial cleanliness. F goes for facial cleanliness, and E goes for what? E goes for environmental sanitation, that is environmental cleanliness. Okay, so please remember, what do we mean by safe strategy? S for surgery, A for antibiotics, F for facial cleanliness, and E for environmental sanitation. Important point to be remembered for PSM2. Now, treatment. What is the usual treatment? The drug of choice for trachoma. Anybody in the chat box? This is our question, right? The drug of choice for trachoma. So please tell me, what is the drug of choice for trachoma? In the meanwhile, I'll be telling you about prophylaxis. For prophylaxis, usually what happens in the countries where trachoma is endemic, trachoma is present throughout the year, we usually give a prophylactic therapy, which is also known as blanket therapy. Okay, this prophylactic blanket therapy, it is usually given with tetracycline. Okay, it is usually given with tetracycline ointment. So please remember, tetracycline is used for prophylaxis of trachoma, known as blanket therapy. Yes, what is the drug of choice? Yes, very good guys, it is your azithromycin. It is your azithromycin. So please remember, azithromycin is the drug of choice in cases of trachoma. Etiology, please remember, Chlamydia trachomatis is the organism which causes trachoma. A to C serovars mainly. D to K serovar of Chlamydia are causing ophthalmia neonatorum or paratrachoma, which is also known as swimming pool blindness. And lastly, L serovar causes LGV, lymphogranuloma venerum, which we will study in derma. Moving back to our question, all of you have answered it right. Option D, azithromycin is the drug of choice in cases of trachoma endemic areas. If they ask about prophylaxis, then your answer should be tetracycline. Doxycycline drugs. Moving further to our next question, that is 18. Pupil and acute iritis is. Okay, so now let's study important features about uveitis. So now, I have already told you what is uveitis, inflammation of the uvea. Uvea is which layer of your eyeball? Uvea is the middle layer of your eyeball, that is your vascular coat of the eyeball. And uvea comprises of, anteriorly it comprises of your ciliary body, and posteriorly it comprises of your choroid, which is the vascular layer, right? So now, if there is anterior uveitis, either there can be iritis, okay, inflammation of the iris, or there can be iridocyclitis, that is inflammation of iris plus ciliary body. So please remember, iritis, inflammation of the iris, iridocyclitis, inflammation of iris along with ciliary body. Both of these comprise of the anterior uveitis. Then intermediate uveitis is what? Pars planitis. Okay, so please remember, pars planitis. As we all know, a ciliary body is divided into two halves. Okay, that is the plain part is known as your pars plana. Okay, and if there is inflammation of this posterior part of your ciliary body known as pars plana, it is known as pars planitis, and which is known as intermediate uveitis. And last is your posterior uveitis. Okay, posterior uveitis is what? Generally, posterior uveitis is the inflammation of your choroid, the posterior most part. So choroiditis is also known as posterior uveitis. I hope this is clear to you now. Very important. Okay, now usually uveitis, mainly anterior uveitis, okay, you need to remember, because anterior uveitis is very much important. Okay, the first thing that you need to remember, anterior uveitis, the most important cause of anterior uveitis, pata nahi, matlab it is idiopathic. So please remember, the most important cause of anterior uveitis is idiopathic, but it is seen to be associated with some arthropathies. Okay, it is usually seen to be associated with HLA-B27 related arthropathies like ankylosing spondylitis, okay, reactive arthritis. All these HLA-B27 associated arthropathies are associated with anterior uveitis, right? Now, what are the clinical features usually seen in cases of anterior uveitis? There would be unilateral, painful diminution of vision. So please remember, diminution or loss of vision can also be seen. So please remember, सबसे पहले तो unilateral है, only one eye is affected. Second, it is painful, definitely inflammation hai, pain would be there, and there is loss of vision. So please remember, you need to remember in which cases there is painless loss of vision, in which cases there is painful loss of vision. So unilateral painful decrease in vision is seen in cases of anterior uveitis. Moving to the signs. Okay, signs are most important in cases of anterior uveitis. First are, as I've always told you, wherever there is inflammation, there would be infiltration, matlab presence of cells. Okay, so cell infiltration would occur, and these cells would be seen in the anterior chamber, which will affect the vision. Okay, cells would be seen in the anterior chamber, which will affect the vision. Second thing is your keratic precipitates. Okay, you can see keratic precipitates. What do we mean by keratic precipitates? Those are the heavy cells which are stuck behind the cornea. Okay, so some of the heavy cells, they get stuck behind the cornea, okay, on the posterior aspect of the cornea. So these heavy cells would be known as your keratic precipitates. Okay, so please remember this. Next one is your arch triangle. These keratic precipitates, anteriorly if we see them, these would actually, they would be stuck to the cornea in a triangular fashion, and this triangular fashion is known as your arch triangle. So triangular configuration of your keratic precipitates is known as your arch triangle. It is known as your arch triangle. So please remember, arch line were scarred lines in cases of trachoma, whereas arch triangle is configuration of keratic precipitates seen in cases of anterior uveitis. I hope this is fine. Next would be flare. जहाँ cells है वहाँ flare होगा, obvious ही बात है, right? So there would be flare. What are the changes seen in pupil? So important one, please remember, in cases of anterior uveitis we usually see a small and a irregular pupil. We can see a small, that is a constricted, okay, we can see a small constricted pupil, okay, constricted myotic pupil, and which is irregular, okay, it changes its shapes, and okay, it starts changing its shape in the early course of the disease, but in the late course of the disease क्या हो जाता है, it forms synechiae. And what do we mean by synechiae? So please remember, synechiae means adhesions, okay, so synechiae means adhesions, चिपक जाता है ये. Okay, so it forms synechiae, and these synechiae, if they are formed all around the pupil, okay, if they are formed all around the pupil, that is in 360-degree fashion, it can lead to a condition known as iris bombay. It can lead to a condition known as iris bombay. So please remember, if synechiae are all around in 360-degree, okay, circumferential synechiae ban jate hain, then it is known as iris bombay. Okay, usually the pupil is small and irregular. Okay, whereas if the condition progresses and now it is a chronic uveitis. So in cases of chronic uveitis, what do we usually see? We usually see a dilated pupil. Okay, in early stages we see a constricted pupil, whereas in late stages of chronic stages we can see a dilated pupil, and which is irregular in shape, and this is what it is. The image which you can see over here, it is your festooned pupil. Okay, this image which had come earlier in NEET PG. So please remember guys, this is your festooned pupil, okay, which is usually seen in chronic anterior uveitis. Okay, I hope this thing is fine with you now. Next one is your iris. Iris में क्या changes दिखेंगे? You can see two types of nodules. First are your Koppes nodules, which are seen at the pupillary margins, and second are your Busaka's nodules. B for Busaka, B for base. So Busaka's nodules at the base of the iris. So please remember, Koppes and Busaka's nodules are seen in cases of anterior uveitis. Okay, and what is the drug of choice in cases of uveitis? So we usually prefer topical agents. What is the drug of choice in cases of anterior uveitis? Anybody in the chat box, if you can answer this? So please answer it guys. The drug of choice in cases of anterior uveitis is what? Topical steroids. So please remember, topical steroids is the drug of choice in cases of anterior uveitis. Okay, and in cases of acute uveitis, if I say it acute, it means the patient is presenting to you with excessive pain in emergency, right? सबसे पहला primary aim क्या होना चाहिए तुम्हारा? The primary aim should be to relieve the pain of the patient, right? So in cases of acute conditions in emergency, we usually try to relieve the pain, and in cases of acute uveitis, the primary aim is to relieve the pain, which is not done with steroids. So in cases of acute uveitis, what would be the drug of choice then? Please remember guys, this most of the times we mark it wrong. In cases of acute uveitis, the drug of choice should be the agents which can relax the ciliary muscle. What happens in anterior uveitis? I told you, in inflammatory conditions usually the ciliary muscles undergo spasm, and as the ciliary muscle undergoes spasm, they lead to excessive pain. No, so we need to relax the ciliary muscles. Therefore the drug of choice in acute uveitis should be, any answers? We have discussed this earlier. Those were your very good Anuj, it is your cycloplegics. So please remember, in cases of acute uveitis, the answer should be cycloplegics. If they only ask about uveitis, then your answer should be steroids. Okay, cycloplegics like atropine, homatropine. Okay, so here in cases of pupil in acute iritis would be what? In cases of acute or early stages of the disease, the pupil would be constricted, it would be a small myotic irregular pupil, whereas in late stages or chronic stages of the disease, it would be what? It would be a dilated irregular festooned pupil, right? I hope this is all. Now moving further to our next one, that is your question number 19, which states Herbert's pits are seen in. So Herbert's pits are what? These are your Herbert's pits. Okay, what you can see, Herbert's pits, these are your scarred depressed follicles, the follicles which you see. Okay, these are your scarred depressed follicles. If these follicles undergo scarring, they would appear something like this. And these scarred depressed follicles on the upper limbus, okay, limbus is what? The sclerocorneal junction, where the sclera and the cornea meet, right? So on the upper sclerocorneal junction or on the upper limbus, these Herbert's pits are seen. And Herbert's pits are the most pathognomic feature of which disease? They are the most pathognomic feature of, I knew this, guys, you are confusing it, please guys, you are confusing it again. If we change the name, please remember guys, if we change the name, if the examiner changes the name, your answer should not change. Please remember, your answer should not change. I am just giving you a hint. Vernal keratoconjunctivitis is also known as spring catarrh, also known as summer conjunctivitis. Okay, atopic conjunctivitis is due to some allergy. Okay, it is due to some allergy seen usually in cases of asthmatic patients. Okay, hay fever like patients. Next, gonococcal conjunctivitis is due to gonococca, Neisseria gonorrhoeae. And last is your chlamydial conjunctivitis. Chlamydial conjunctivitis means what? It means trachoma. So please remember, chlamydial conjunctivitis is none other than trachoma. Yes, please remember, trachoma ka most pathognomic features are these Herbert's pits. So please remember, chlamydial conjunctivitis and trachoma are one and the same thing, and the most pathognomic feature of trachoma is what? These Herbert's pits. So don't get confused, naam change hota hai, so please always I ask you to read alternative names. Okay, baad wale dusre naam bhi yaad rakhne hain, important hai, right? Any of the name can come. Okay, very good guys. Now moving further with this second image. Is image mein kya dikh raha hai? Similar looking image hai, but isme koi depressed follicles nahi dikh rahe. Okay, here we cannot see any depressed follicles, rather we can see some accumulation happening, and this is a eosinophilic accumulation. Okay, this eosinophilic accumulation which is seen, these are known as what? This eosinophilic accumulation which are seen, these are known as Horner-Tranta spots. These are known as what? Horner-Tranta spots. And Horner-Tranta spots are the most pathognomic feature for what? Horner-Tranta spots are the most pathognomic feature for vernal keratoconjunctivitis. Okay, so this image is of vernal keratoconjunctivitis or VKC. Okay, so please remember, Horner-Tranta spots are also located on the upper limbus. You need to differentiate between both of these conditions. The other features that can be seen in cases of VKC are what? There, in this condition also we can see some papillae, but these papillae have a characteristic appearance. These papillae are seen in a cobblestone fashion. So please remember, we can see a cobblestone palpebra or cobblestone mucosa usually in cases of VKC or vernal keratoconjunctivitis. Okay, important one. Along with that, we can see Maxwell-Lyon sign. What we can see? Maxwell-Lyon sign. That is a ropey, thick ropey discharge can be seen. Okay, thick ropey pus purulent discharge is seen. That is known as your Maxwell-Lyon sign. Okay, along with that, we can see pseudogerantoxon. Okay, a pseudogerantoxon will be seen surrounding the cornea, and lastly we can see a shield ulcer. These are the important features that you need to remember. Very good guys. Okay, these are the important features about VKC that you need to remember. Remember guys, VKC, chlamydial conjunctivitis, that is trachoma, and flight-tenular conjunctivitis, all of these three are important. Okay, flight-tenular conjunctivitis important, yaad rakhni ek baat ki flight-tenular conjunctivitis is associated with tuberculosis. Okay, so a correlation can be given in the question. A TB patient presenting with some nodule vagera. Okay, so you something should click in your mind ki acha ye flight-tenular conjunctivitis ho sakta hai, right? So this is how you just correlate things. Next is your constantly changing refractive error is seen in. Constantly changing refractive error is usually seen in. So what is the answer? Constantly changing refractive error is seen in. So as we all know, in cases of diabetes mellitus, cataract can develop over time. Okay, the sugars which are there, excess of glucose is converted to its alcohol form, that is known as sorbitol. Okay, so please remember sorbitol accumulation can lead to a diabetic cataract. We will see the image. Next is a traumatic cataract, mostly seen with blunt traumas. Third is your Morgagnian cataract, which is a hypermature cataract due to liquefaction of the cortex. Yes, in cases of diabetic cataract, guys, we can see a changing refractive error, but it is associated with usually when the glycemic control fluctuates. Okay, जब sugar ज़्यादा होगी कम होगी, along with that the refractive error might change. Okay, but it is not constant. Not every time it would change. So constantly changing refractive error, it is usually seen in cases of option A, intumescent cataract. So what do we mean by intumescent cataract? In cases of intumescent cataract, there is actually swelling or congestion of the lens. Okay, so there is swelling and congestion of the lens due to imbibition of fluid inside it. Okay, fluid accumulates inside the lens that causes this swelling or congestion of the lens, and it is usually associated with which conditions? It is due to infrared light exposure. Okay, infrared light exposure, due to radiation exposure, and due to heat waves or burns. Okay, all these conditions may we can see a intumescent cataract in which we can see a constantly changing refractive error. Yes, it is also seen in cases of astigmatism. Very good. Okay, important one. Moving further, I hope this is important and you need to remember this. Moving further to our question number 21, that says organ laser trabeculoplasty is done in. Organ laser trabeculoplasty is done in cases of, answer, organ laser trabeculoplasty is usually done in cases of So please remember guys, usually in cases of secondary glaucoma, we try to treat the primary cause, whatever is the cause. Like in cases of lens induced glaucoma, rather than treating the glaucoma, we would first treat the lens. If there is cataract, we'll try to remove that cataract, right? We try to operate the cataract itself. So in cases of secondary glaucoma, usually we treat the primary cause. So the answer over here is option D, open angle glaucoma. So please remember guys, usually argon laser trabeculoplasty. Okay, what do we mean by trabeculoplasty? What do we understand by this? Trabeculo, that is your trabecular meshwork, and plasty means reconstruction. So please remember, the trabecular meshwork is defective. Okay, there is some pathology in the trabecular meshwork. We need to reconstruct it. That is known as trabeculoplasty. It is done with the help of your argon laser, and it is usually done in cases of open angle glaucoma. Okay, it is usually done in cases of open angle glaucoma when the medical treatment fails. Okay, when it is done, it is usually done when the medical therapy fails or when there is decreased compliance seen in this patient. Patient dawai nahi kha raha hai. Okay, the patient is not taking medications. In those conditions or when the medical treatment fails, then we perform a surgery known as argon laser trabeculoplasty. Moving further to our next one. Question number 22, keratometry is done to assess. This is a very simple question guys, but we tend to make mistakes over here, and I don't want any of you to make mistakes in this simple question. Keratometry is done to assess what? Keratometry से क्या पता लगाते हैं? This image is keratometry. Okay, so what do we assess by keratometry? So first of all, I'll tell you, first is corneal sensations. So please remember, corneal sensations are assessed by esthesiometry. Okay, corneal sensations are assessed by esthesiometry, and this is esthesiometry. Okay, this image you need to remember. Okay, corneal sensations are assessed by esthesiometry. The second option is corneal endothelium. As we all know, the cells in the corneal endothelium are counted with the help of what? With the help of what? The cells in the corneal endothelium, they are usually counted with the help of an instrument known as specular microscope. Okay, specular microscope. कितना होता है normal endothelial cell count? It is 2500 cells per square millimeter. Less than 500 leads to corneal opacity. Okay, so याद रखना, corneal endothelium के लिए we usually prefer specular microscope. Okay, next is your corneal thickness. For corneal thickness, we use usually pachymetry. Pachymetry. Okay, and this is your pachymetry. Okay, so please remember, this is the image of pachymetry, which is used to assess corneal thickness. And the last one is your corneal curvature. So please remember, option D is your right answer. Keratometry is used to assess corneal curvature. Okay, this is the image of keratometry. Here she is assessing the corneal curvature. Okay, so please remember this. These are the important images that you need to remember guys. Okay, moving further, As per WHO classification of xerophthalmia, X2 is what? Okay, please tell me this. In the meanwhile, I'll be telling you what, as we have already discussed, xerophthalmia is due to which vitamin deficiency? It is due to vitamin A deficiency. Okay, it is usually vitamin A deficiency which leads to xerophthalmia. And according to WHO classification, what it is? So WHO classification for xerophthalmia, let's study this first. Okay, so xerophthalmia means dryness of eyes. Okay, usually. So first is X1A. X1A, first of all, it starts with conjunctival xerosis. सबसे पहले क्या dry होगा? Conjunctiva. Okay, so there is conjunctival xerosis. X1B. Okay, second is your X1B, where there is what? There are these Bitot spots. The image which you can see over here, these are your Bitot spots. Okay, toothpaste like plaques are seen on the sclera. These toothpaste like plaques on the sclera are known as Bitot spot. Very important. Image was asked in PSM. Okay, multiple times. So please remember, X1B is your Bitot spots. Then X2 is what? X2 is what? Yes, very good. Most of you are right. It is option D, corneal xerosis. Yes, X2 is corneal xerosis, dryness of the cornea now. X2 is corneal xerosis. X3 is what? It is corneal ulceration. It is also divided in X3A and X3B. Not important to remember. This is important. X3 is corneal ulceration, right? What is XN? XN means night blindness. XN means night blindness, also known as nyctalopia. Usually it is the first symptom. Okay, usually it is the first symptom in cases of xerophthalmia. The patient will present to you with complaints of night blindness or nyctalopia. Okay, usually that is important. If they ask you about the first sign, then it would be conjunctival xerosis. I am talking about sign. Okay, then it would be conjunctival xerosis. Because conjunctival xerosis, the patient cannot assess himself. You need to assess as an you need to assess as a doctor, right? Then what is the most pathognomic feature of xerophthalmia? It is your Bitot spots. Okay, those are the most pathognomic. Now what is XF? XF is your xerophthalmic fundus. Okay, now the retina or the fundus is dry. That is xerophthalmic fundus. And what do we mean by XS? Now the corneal ulceration would be scarred. Now it would lead to xerophthalmic scarring. Okay, so please remember, it is xerophthalmic scarring. S means scar, right? I hope this is clear to you now. Let's move on to our next question, guys. And that says, ectopia lentis is seen in which condition? Okay, so please remember, guys, ectopia lentis is seen in which condition? What do we mean by ectopia lentis first? Ectopia lentis is what? It is subluxation of lens. Ectopia means क्या? अपनी original place पे नहीं है. Okay, lentis means lens. So subluxation or dislocation of lens is known as ectopia lentis. It is dislocated or subluxated from its original position. So now let's see what is the most common cause of ectopia lentis. The most common cause of ectopia lentis is Marfan's syndrome. Most common cause of ectopia lentis is Marfan's syndrome. And in which direction the lens would be dislocated in Marfan's syndrome? So the most common direction in which the lens is dislocated is your superotemporal. Okay, so superotemporal direction, important one. Okay, so superotemporal subluxation is seen in cases of Marfan's syndrome, which is the most common type of subluxation seen. Next important one is your Marchand-Sani syndrome. Okay, it is also important. And which type of subluxation is seen in Marchand-Sani syndrome? So please remember, in Marchand-Sani syndrome usually we can see forward subluxation. Okay, आगे आ जाती है lens. Then we can see forward subluxation in Marchand-Sani syndrome. And one more important is homocystinuria. In homocystinuria we can see ulta from Marfan's, that is infranasal subluxation. Okay, infranasal, this way, infranasal subluxation is seen. So please remember, the most common subluxation if asked, it is superotemporal. Most common cause, Marfan's syndrome. Okay, important one. Infranasal is seen in cases of homocystinuria, and the other causes can be pseudoexfoliation, hyperlysinemia, Ehlers-Danlos syndrome, or Buphthalmos, that is bullseye. Okay, all these conditions can lead to ectopia lentis. So the answer to this condition is option A, homocystinuria. Okay, in Wilson's disease we have already discussed. In Wilson's disease we can see what? We can see a KF ring, that is a Kayser-Fleischer ring, due to copper deposition in the descendants membrane of cornea. Along with that we can see a sunflower cataract. Okay, we can see a sunflower cataract. We'll see this now. Moving further to our next question, which states blowout fracture can be due to. So please remember, blowout fracture is an orbital fracture. So please remember, what is blowout fracture? Blowout fracture is usually an orbital fracture. It is due to trauma. So please remember, blowout fracture is an orbital fracture due to a trauma. Okay, it is an orbital fracture due to trauma. So the orbital walls, there are 4 orbital walls: superior, inferior, medial and lateral orbital walls, right? So which is the most common wall which is fractured in the orbit? So please remember, floor or the inferior wall of the orbit is the most common wall which gets fractured. Okay, so please remember, the most common wall fractured in orbit is your floor or your inferior wall, which is usually made up of your palatine bone, zygomatic bone and maxillary bone. Okay, palatine, zygomatic or maxillary bone, important. But which is the weakest wall? So please remember guys, if they ask the weakest wall of the orbit, then the answer changes. Okay, please remember, though the weakest wall of the orbit is medial wall, it is not commonly fractured. Okay, it is the second most commonly fractured wall. Most common fractured wall is floor, but the weakest wall of the orbit is the medial wall. Okay, important one. Now, what is the cause actually? So please remember, the causes are your blunt trauma. Okay, in this usually it is a blunt trauma with some round object. Blunt trauma with some round object. Any answer? Weakest wall is your medial wall. This is important. And medial wall is formed by what? Medial wall is formed by the sphenoid bone, the maxillary bone, the ethmoid bone and the lacrimal bone. Okay, important ones. Now, any answer? Answer to this question, some of you have answered, I feel so. It is option A, tennis ball injury. So please remember, tennis ball injury usually leads to your blowout fractures. Okay, so please remember this. Moving on to our next question guys, question number 26. A child presents with night blindness, that is nyctalopia, delayed dark adaptation. Which investigation is to be done further? Okay, so just tell me, for dark vision or for dark adaptation, what is responsible? The responsible structure are known as rods, right? For dark vision or for dark adaptation or for night vision, the responsible structure are your rods, right? So now, here what they have said, a child, important, it is a child who is presenting with night blindness or nyctalopia. There is delayed dark adaptation. Which investigation is to be done further? So first thing is, we can keep a provisional diagnosis. हम क्या suspect कर रहे हैं? If the rods are affected, the rods are damaged, okay, it can be most probably retinitis pigmentosa. So please remember, it can be usually retinitis pigmentosa, and we have already discussed in cases of retinitis pigmentosa, what is seen? Retinitis pigmentosa mein, what is the investigation of choice? The investigation of choice in cases of retinitis pigmentosa is what? It is your ERG, that is electroretinography. Okay, it is your electroretinography, important one. Okay, electroretinography is usually used in cases of retinitis pigmentosa. It visualizes all the layers of retina. It usually visualizes all layers of retina. And this is how it differs from electrooculography, where electrooculography only visualizes the retinal pigment epithelium. The 10th or the last layer of retina is visualized by this electrooculography. Okay, important. And retinoscopy is important. We tend to make a mistake over here. ठीक है, उसका नाम retina है, but it is not used for retina. Okay, it is used to find out refractive error. थोड़ा confusing है ना? ठीक है, कोई ना. ठीक है? So please remember, it is usually used to find out some refractive errors. So retinoscopy is used to find out refractive errors. Okay, electrooculography for retinal pigment epithelium, and electroretinography, which visualizes all parts of retina, used for retinitis pigmentosa. Moving further, question number 27. Rosette cataract is seen after. This is very easy, I feel so. Everybody would answer this. Question number 27. Rosette cataract is seen after. So now let's discuss few cataracts first. This is the image, this is the slide. I want you guys to just learn it by heart. Okay, images ढंग से पूरे याद होने चाहिए. रात को भी कोई उठा के पूछे, it should be on your fingertips. Okay, so please remember this. Now the first image that I have shown over here, it looks like what? The cataract over here, it looks like petals. ठीक है, कैसे petals जैसे दिख रहा है ना? See, it looks like petals. Okay, मैं खराब नहीं करूँगा इसको. So it looks like petals, rose petals. Okay, so it is known as your rosette or stellate cataract. इसको क्या बोलते हैं हम? Rosette or stellate cataract, which is usually seen due to blunt trauma to the eye, which is usually seen due to blunt trauma to the eye. I hope this has answered our question already, right? Now next one, what is this? This is greenish yellowish something looking like a tree, and this is a Christmas tree cataract. ये क्या है? Christmas tree cataract, and it is usually seen in which condition? Christmas tree cataract seen in cases of myotonic dystrophy. Myotonic dystrophy mein we can see this Christmas tree cataract. Next one, it is this one. What we can see over here, in this cataract we can see whitish flakes all over, and these whitish flakes resemble snowflakes. Therefore this is known as a snowflake cataract, and snowflake cataract is due to deposition or accumulation of sorbitol, which is a alcohol form of your glucose, and excess glucose condition is seen in which? Excess glucose condition is which? It is diabetes mellitus. So please remember, snowflake cataract is a diabetic cataract due to accumulation of sorbitol. Okay, important one. Next one, this, what is this? This feels like a oil drop, like बराबर, this feels like a oil drop, जैसे कि oil की कोई बूंद गिरी हो. So this is a oil drop cataract. Important point, it is the only reversible cataract. Usually cataracts are irreversible, but the only reversible cataract is the oil drop cataract, and it is seen in which condition? It is seen in cases of galactosemia. So please remember, it is seen in conditions of galactosemia, where galactitol or dulcitol accumulation occurs, and dulcitol or galactitol is what? Alcohol form of your galactose, right? So in cases of galactosemia, where there is excess of galactose, it is converted to its alcohol form, which accumulates, and it leads to this oil drop cataract, which is the only reversible cataract. This question have been asked earlier. Next one, this, in this picture, what you can see? You can see some ring over here. Okay, you can see some ring and a flower like cataract over here. Okay, so this ring and flower like cataract, usually this ring, ये ring कौन सी है? Brownish color ring, usually due to copper deposition. This is your KF ring, and this flower like cataract is what? It is your sunflower cataract. It is your sunflower cataract, right? And this is usually seen in conditions of Wilson's disease, which is copper excess condition, and another condition is chalcosis. Okay, so please remember, in Wilson's disease and chalcosis we can see KF ring and this sunflower cataract. And the last one, yes, most of you have answered it right. This is what? This is your polychromatic luster. Okay, बहुत सारे colors दिखते हैं इसमें. Okay, it is a polychromatic luster, and this polychromatic luster is usually seen in which condition? It is usually seen in complicated cataracts. In cases of complicated cataracts, this polychromatic luster is seen. And how to differentiate it between the Christmas tree and polychromatic luster? So you usually find it, guys, in cases of polychromatic luster, many colors would be seen. This is the first thing. Only greenish and yellow color are seen in cases of Christmas tree cataract, but at times it is difficult, like in this image. Most of them, they are resembling each other. So in this case, mostly the history which is given associated in the question, it would help. Okay, so please remember, always go to the history to have a better diagnosis, right? Only with the image it becomes very much confusing, so they will always give you a history, okay, along with it. Moving further, next one, question number 28, true about pterygium. Okay, what is the right or correct statement or the true statement about pterygium? Okay, so this is our pterygium. What do we mean by pterygium? What is pterygium actually? So please remember, pterygium is a wing shaped fold of conjunctiva. Okay, it is your wing shaped fold of conjunctiva over the cornea. It encroaches the cornea. So please remember, you can see this wing shaped fold of conjunctiva which is encroaching the cornea. This is known as your pterygium. Okay, so what is pterygium? It is the inflammation of cornea? No, it is known as keratitis. Fatty deposition of cornea? No, it is known as gerontoxon usually, or arcus senilis, right? A ring which is formed due to lipid accumulation around cornea. Then conjunctival invasive flap over cornea? Yes. Okay, the answer over here is option C. Conjunctival invasive flap over the cornea is known as your pterygium. What are dead epithelial debris accumulation known as? These are known as drusen. Important. These are known as drusen. Okay, important. Now, what is the basic etiology of your pterygium? So the basic etiology behind pterygium is elastotic degeneration. This question have been asked. The etiology behind pterygium, it is your elastotic degeneration, and this elastotic degeneration occurs due to exposure to ultraviolet B rays. Okay, due to exposure to ultraviolet B rays, there is elastotic degeneration, which leads to this formation of invasive flap of conjunctiva encroaching the cornea, which is the most common location of pterygium. So usually we find it on the nasal side. Okay, we usually find it on the nasal side. Okay, on the medial canthus we can find it. Then what is Stocker's line? This question has also been asked. What is Stocker's line? Stocker's line is line of iron deposition. Okay, so please remember, Stocker's line is actually the line of iron deposition. Just a minute guys, it is a line of iron deposition over the head of the pterygium, over the head of pterygium. तो यहाँ पे अगर iron deposit हो जाता है, this is known as your Stocker's line, right? And in cases of pterygium, it is usually not treated. Okay, it is usually not treated mostly. Okay, it does not cause any visual abnormality, but if it causes vision loss, or if it is causing inability to visualize, then in those cases we usually prefer a surgery. Okay, and this surgery is known as what? This surgery is actually excision. हम निकाल के फेंक देते हैं वो invasive flap. Okay, so there is excision and autograft. There is excision and autograft. Okay, so we cannot leave the sclera like that exposed to the external environment. Therefore we actually take conjunctiva from the same eye or from the another eye and we place it over the exposed part. Okay, so excision and autograft is the surgery of choice in cases of pterygium. I hope this is fine with you now. And one more resembling name is pinguecula. Okay, this was a question asked. Okay, pinguecula, it is actually a nodule like appearance. Okay, it is actually a nodule seen over the sclera. Okay, I'll show you the image in the clinical case discussion. Yes, for cosmetic purposes only we usually do surgery in cases of pterygium. Then next is your question number 29. For laser iridotomy, which laser is used? Okay, which laser is used in cases of laser iridotomy? Otomy means what? Opening. Okay, we are opening the iris. We are creating some holes in the iris with some laser. Which is the laser used? So let's discuss what is actually laser iridotomy. So please remember guys, laser iridotomy is a procedure which is the treatment of choice in cases of angle closure glaucoma. Okay, laser iridotomy is a treatment of choice in cases of angle closure glaucoma. Please remember, in open angle glaucoma we were performing what? In open angle glaucoma we were performing argon laser trabeculoplasty it was. Okay, and in angle closure glaucoma we are performing peripheral laser iridotomy. But important thing, we try to treat glaucoma initially with medication. So please remember, drugs are primary or mainstay of treatment in cases of glaucoma. But in cases if the medical treatment fails, then we move on to our surgeries. In cases of angle closure glaucoma, okay, what happens? The angle is closed. Okay, and the angle is closed due to some abnormal adhesions which are formed. चिपक जाता है. Okay, so the iris is actually adhered to something. Okay, the anterior structures like cornea. So please remember, if there are adhesions or this synechiae, then we usually perform surgeries. Okay, if this synechiae, the posterior synechiae, if they are less than 180 degree, okay, if they are not more than 180 degree, if they are just less than 180 degree, in those cases we usually perform this laser iridotomy. We usually perform this peripheral laser iridotomy. Okay, with the help of which laser? With the help of ND-YAG laser. With the help of ND-YAG laser. Important thing. And if the synechiae or the adhesions are more than 180 degree, in this case we need to perform a trabeculectomy. We actually cut the trabecular meshwork. Okay, we actually cut the trabecular meshwork to open it properly. More than 180 degree adhesions, trabeculectomy. Less than 180 degree, peripheral laser iridotomy with ND-YAG laser. So which is the laser? Answer over here is option A, ND-YAG laser. Important one, right? Now please remember guys, ND-YAG, we'll discuss about three important lasers that you need to remember from ophthalmology. First is your ND-YAG laser. What is the wavelength of your ND-YAG laser? Wavelengths are important. It is a 1064 nanometer. The wavelength of ND-YAG laser is 1064 nanometers, and it is usually indicated in conditions like, first is peripheral laser iridotomy in angle closure glaucoma, and second condition is PCO for posterior capsulotomy. So we perform posterior capsulotomy. We open the posterior capsule of the lens, okay? And this posterior capsule of the lens is actually open for what? To removing this opacification which has been formed, okay? The posterior capsular opacification, or PCO, it is also known as after cataract or secondary cataract, which is a usual or the most common complication after cataract surgery. So please remember guys, PCO is the most common complication after cataract surgery. It is also known as after cataract or secondary cataract, which is usually treated by posterior capsulotomy. And in cases of posterior capsulotomy also, we use this ND-YAG laser, for which the wavelength is 1064 nanometers, right? Next is your ND glass laser. Okay, ND glass laser is usually used in cases of a cataract surgery. First of all, remember the wavelength. The wavelength of ND glass laser is 1053 nanometers. Wavelength of ND glass laser kitna hai? 1053 nanometers, and it is usually used in cases of FLACS. What do we mean by FLACS? FLACS is a femtolaser assisted cataract surgery. FLACS is femtolaser assisted cataract surgery. And last is your excimer laser. This excimer laser is a argon fluoride laser. Okay, this argon fluoride laser has a wavelength of 193 nanometers. It has a wavelength of only 193 nanometers, and it is used in conditions like photoablation. It is used in conditions like photoablations. I hope these things are clear to you now. And CO2 laser guys, please remember CO2 laser is usually used in cases of ENT, जब हमें कॉर्डेक्टमी करनी होती है. Okay, vocal nodules या vocal polyps जब बन जाते हैं, we usually prefer this CO2 laser cordectomy वगैरह, right? In cases of laryngeal cancers also in T1 stage. I hope you know this, or you will study this in upcoming days. Next one, question number 30. A newborn is hypermetropic by. So now here you need to know the differences between newborn eye and an adult eye. A newborn is hypermetropic. उन्होंने तो directly दे दिया newborn is hypermetropic. Sometimes they can ask newborn eye is either myotic or hypermetropic. So please remember, newborn is usually hypermetropic because the axial length of the eyeball is smaller, right? In adult it is of normal size. ठीक है? So what happens usually, if the rays of light falls, it should fall on the retina properly. This is known as emmetropia. This is known as emmetropia. If the rays of light are falling behind the retina, then this is known as hypermetropia, and which is usually seen in conditions when the axial length or the anteroposterior diameter of the eyeball is smaller. And when the anteroposterior diameter of the eyeball is larger, the rays of light would fall in front of the retina. Then also the image would not be found properly, and this is known as myopia, right? So this is myopia. Hypermetropia is treated with what? Convex glasses, and myopia is treated with what? Concave glasses. I hope refractive errors are clear to you now. Yes, answer is option B, that is plus 2.5 diopters. Okay, plus 2.5 diopters. So let's see important changes between a newborn eye and an adult eye. So first of all, about the anteroposterior diameter. The anteroposterior diameter, also known as the axial length of the eyeball, which is usually seen by an ultrasound A scan, it is 16.5 mm in cases of a newborn eye. It is 16.5 mm in a newborn eye, and it grows in size to 24 mm in an adult eye. So the normal axial length of an adult eyeball is 24 mm. It is 24 mm. Don't forget this. Then refractive error. In cases of newborn eye, we can see hypermetropia due to the decreased axial length. We can see hypermetropia. Kitna hota hypermetropia? Usually plus 2 to plus 3 diopters. So the closest answer should be marked, which is plus 2.5 diopters in this case. Okay. Whereas adult eye, normally an adult eye is emmetropic, right? Normally adult eye is emmetropic, no refractive error is there. Next is your corneal size. Corneal size in newborn eye, it is 9 mm, whereas it grows up to 11 mm in 2 years. So please remember, at 2 years of age, the cornea attains its maximum adult size, which is 11 mm. Okay, which is 11 mm. Next, what is the lens size in newborn? Lens size in newborn is 6.5 mm, which grows up to 10 mm in an adult eye. Next is power of accommodation. So please remember, power of accommodation is highest in cases of newborns. Okay, power accommodation is highest in cases of newborns, whereas it decreases with age. It decreases with age, right? जैसे जैसे age बढ़ेगी वैसे वैसे power of accommodation कम होती जाएगी. Moving further, question number 31. In dacryocystorhinostomy, okay, dacryocystorhinostomy, lacrimal gland is open in two. Easy, just remember Latin. Okay, क्या है? Dacryocysto. Dacryo means lacrimal, cysto means sac. so lacrimal sac. Rhino means nose, stomy means opening. So a new opening is created for your lacrimal sac. This procedure is known as dacryocysto-rhinostomy. So in dacryocysto-rhinostomy, lacrimal gland is opened into what? In which meatus? As we all know. First of all, the normal lacrimal gland flow, you know, right? So please remember the normal lacrimal gland, the flow is the tears are they go into your lacrimal sac. From there they go into your nasolacrimal duct. Sorry guys, just a minute. Apologies. Then they go to your nasolacrimal duct, and this nasolacrimal duct actually opens into where? It opens into your inferior meatus. It opens into your inferior meatus. Okay, ये तो पता है ना, inferior meatus में open होता है. Okay, in inferior meatus only nasolacrimal duct opens. Important question है. Middle meatus में there is a osteomeatal complex where the maxillary, frontal and the anterior ethmoidal sinus opens. Then superior meatus में the posterior ethmoidal sinus opens, and supreme meatus में or sphenoethmoidal recess में the sphenoid sinus opens. If you are not well acquainted with ENT, no worries guys, you will get to know these things also. Okay, don't worry. So now what is dacryocystitis? Itis is inflammation again. So dacryocystitis is inflammation of your lacrimal gland. Okay, inflammation of lacrimal gland or lacrimal sac is known as your dacryocystitis. It can be either acute, it can be chronic, or it can be congenital. Cystitis would present suddenly, okay, with symptoms, okay, and it would be painful, right? Acute conditions are painful, and the most common cause of acute dacryocystitis is what? Staph aureus. The most common cause of acute dacryocystitis is Staph aureus. You need to remember this. Whereas chronic dacryocystitis, it is a painless swelling. Okay, it is usually a painless swelling. इसलिए ध्यान नहीं जाता. Attention is not given to this painless swelling which keeps on growing. Okay, so this painless swelling, okay, is seen along with watering. As there is blockage, the lacrimal duct cannot drain properly. Therefore, there is always watering of eyes seen. Okay, so please remember, watering of eyes along with painless swelling is seen in cases of chronic dacryocystitis. For that, the treatment of choice is dacryocysto-rhinostomy. About the procedure we are studying right now. Next is your congenital. Congenital means which is present from the birth itself. So for congenital dacryocystitis, the treatment varies. Okay, and this was asked in AIIMS also. So till 1 year of age, okay, till 1 year of age, the treatment of choice for congenital dacryocystitis is Krigler sac massage. Okay, it is your Krigler sac massage. On the medial aspect, you actually massage the sac. Okay, till 1 year you actually perform Krigler sac massage, with which usually the symptoms are relieved. Second, from 1 to 4 years of age, the preferred treatments are either probing or syringing. In 1 to 4 years of age, the preferred treatment options are probing or syringing. And lastly, more than 4 years of age, now the child has grown. Now the treatment of choice would be DCR, that is your dacryocysto-rhinostomy, again the surgery, right? But only more than 4 years of age. Please remember this, okay? And in this case, when a dacryocysto-rhinostomy is performed, the nasolacrimal duct, instead of the inferior meatus, it is opened into a wide meatus, that is your middle meatus, where 3 of the sinuses open. Option C, middle meatus, is your right answer. I hope now this helps you. Moving further, question number 32, which is the therapeutic indication of keratoplasty? What do we mean by keratoplasty? Kerato means cornea, plasty means again reconstruction. So reconstruction of your cornea is known as keratoplasty. And when it would be indicated? So just tell me the answers now. The therapeutic indication of keratoplasty is what? So usually, please remember guys, reconstruction of cornea usually would be preferred in conditions like, so please remember, whenever the cornea is injured, okay, that is either in cases of trauma or chemical or mechanical injuries or physical injuries to the cornea, okay. Then next one, fungal, bacterial or viral keratitis, or fungal, bacterial or viral corneal ulcers, because as we all know, viral ulcers, usually in these corneal ulcers, what happens, the epithelial is defective, okay? The epithelial of the cornea degenerates, right? Therefore a reconstruction of the cornea is required. Okay, along with this there can be burns and other causes which are also an indication of keratoplasty. So the answer over here should be option B, very right, perforated corneal ulcer. Okay, perforated corneal ulcer. Okay, in keratoconus usually we can perform a keratoplasty, but that is not a preferred choice. What is keratoconus? A conical cornea. Okay, cornea कुछ ऐसा हो जाता है. In that case, the preferred treatment option is C3R. That is corneal collagen cross linkage along with riboflavin drops. I'll explain it to you further in the last question. Okay, I hope things are clear to you now. This is the only thing that you need to remember over here. Moving further guys to our next question, question number 33. Site of internal hordeolum is. Site of internal hordeolum is. So let's discuss what are the different types of inflammation of your eyelids. So as we all know, the eyelids usually contain different glands. Okay, there are important 3 glands that are seen: Zeiss gland, meibomian glands and Moll glands. Okay, so please remember Zeiss, meibomian and Moll glands. So now first is internal hordeolum. What is internal hordeolum? It is acute inflammation. Okay, it is acute inflammation of your meibomian gland. Okay, please remember internal hordeolum is your acute inflammation of the meibomian gland, important one. Second is what? External hordeolum, and this external hordeolum is also known as stye, not style, it is also known as stye. ठीक है, external hordeolum usually सबको होता है, usually आँखें आ जाती है या आँखें आ जाती है conjunctivitis. This external hordeolum is known as stye. Okay, it has different names in different languages. So what is external hordeolum? It is your acute, painful, suppurative inflammation. Okay, it is acute, painful, suppurative inflammation of which glands? Of your other 2, that is Zeiss and Moll glands. So please remember, Zeiss and Moll glands ka acute painful suppurative inflammation is known as what? It is known as your external hordeolum, also known as stye. And last and the most common cause of stye or external hordeolum is again what? The normal commensal, that is your Staph aureus. Okay, Staph aureus. Last one is chalazion, which is the most important one. Questions have been asked repeatedly from chalazion. What is chalazion? Chalazion is a meibomian or a tarsal cyst. Okay, so what is chalazion? Chalazion is usually a meibomian or a tarsal cyst. Okay, a fluid accumulation or cystic swelling is seen in the meibomian gland. This is your chalazion. Important point about chalazion: it is recurrent. Okay, it is recurrent. Recurrence is very common in cases of chalazion. Okay, and in this cases what can be seen? It is due to a chronic granulomatous inflammation. It is due to a chronic granulomatous inflammation of your meibomian glands. So a chronic granulomatous inflammation of meibomian glands can lead to a cystic swelling in the gland known as meibomian cyst or a tarsal cyst, commonly known as chalazion, which is recurrent, बार बार होता रहता है. And the treatment of choice in cases of chalazion is incision and drainage. Incision and drainage. So what is this? This is your chalazion. So please remember, this is your chalazion which is seen over here. Okay, and it is held with what? So please remember, it is held with the chalazion forceps, and this image was asked in December examination. Okay, so please remember, chalazion forceps image was asked in December examination. Okay, these are your chalazion forceps. That is why I have included this image over here. So site of internal hordeolum is what? Option B, meibomian gland. One important thing that you need to remember about your eyelids: which is the most common malignant tumor of your eyelids? This is very much important. Which is the most common malignant tumor of your eyelids? And the answer is basal cell carcinoma. Please remember, the most common malignant tumor of eyelid is basal cell carcinoma. If the question is the most common primary malignant ocular tumor, okay, most common primary malignant ocular tumor, that the answer would be retinoblastoma. Okay, retinoblastoma. Whereas if they ask most common primary malignant orbital tumor, orbit की अगर बात कर रहे हैं, then the answer would be rhabdomyosarcoma. Okay, rhabdomyosarcoma, tumor of your skeletal muscles or striated muscles, is known as rhabdomyosarcoma. Right? I hope these things are clear to you. Moving further now to our next question: how many years does it take to develop retinopathy in type 1 diabetes mellitus? Okay, so type 1 diabetes mellitus, how many years does it take to develop retinopathy? As we all know guys, usually in cases of diabetes mellitus, okay, either in type 2 or type 1, any of those. In diabetes mellitus, we can see either macrovascular complications and microvascular complications. Macrovascular complications are usually atherosclerosis, coronary artery disease, right? Whereas microvascular complications are diabetic retinopathy, diabetic neuropathy, and diabetic nephropathy, right? Here we are discussing about diabetic retinopathy. So please remember, guys, usually in cases of diabetic patients, we usually give them an advice for screening. Okay, they undergo screening for all these microvascular complications. And for diabetic retinopathy, the screening for diabetic retinopathy in cases of type 1 diabetes mellitus and in cases of type 2 diabetes mellitus differs. Okay, the screening in cases of type 1 diabetes mellitus, it is usually started 5 years after the diagnosis. It is usually started 5 years after the diagnosis. So please remember, in cases of type 1 diabetes mellitus, as we all know, as there is insulin deficiency, it is usually diagnosed earlier. Okay, it is usually diagnosed earlier in course. Therefore, the microvascular complications have not been yet developed. Therefore, from 5 years after the diagnosis, we ask the patient to undergo screening for diabetic retinopathy. But in cases of type 2 diabetes mellitus, which is very common, and here the patient mostly presents to you along with microvascular complications, right? It is usually diagnosed late in the course. Therefore, in cases of diabetes mellitus type 2, for diabetic retinopathy, the screening should be started ASAP. The best answer would be ASAP, that is as soon as possible. If it is not present in the options, then your answer can be at the time of diagnosis. Okay, here they have asked about what? Type 1 diabetes mellitus. So usually in type 1 diabetes mellitus, it takes usually option A 1 to 5 years to develop diabetic retinopathy or any of the microvascular complications. Okay, moving further, these are some features that you need to remember about diabetic retinopathy, guys. Okay, what are the important risk factors for diabetic retinopathy? So please remember the important risk factors of diabetic retinopathy. First is duration of diabetes mellitus, that we have already discussed. Duration of diabetes mellitus is rather the most important risk factor. It is the most important risk factor for developing microvascular complications. Next is your poor diabetic control. Okay, if there is poor sugar or poor diabetic control, then it can lead to your microvascular complications. And last is your comorbidities. So comorbidities are associated diseases like hypertension, if there, renal diseases, any of these conditions if are associated, then they can immediately progress to diabetic retinopathy. Then diabetic retinopathy usually can be in two stages. First is non-proliferative and second is proliferative diabetic retinopathy. In cases of non-proliferative diabetic retinopathy, the earliest feature which is seen, okay, this is a very common question which has been asked. The earliest feature in cases of NPDR are your microaneurysms. The earliest feature are your microaneurysms. This is the fundus image. What do we mean by fundoscopy actually? ठीक है, fundoscopy का मतलब बता दो. So fundus is what? It is a visible part of retina which is visualized on an ophthalmoscope, either on a direct or an indirect ophthalmoscope. जितना भी part of retina is visible, okay, that is known as your what? It is known as your fundus. Okay, and therefore the investigation in which we can visualize the retina is known as fundoscopy. In this fundoscopic picture, you can see the earliest sign. Okay, the earliest sign of NPDR, that is your microaneurysms. Okay, microaneurysms are seen in small retinal capillaries. Which is the most specific sign? If they ask you about the most specific sign, then the answer would be dot blot hemorrhages. Then the answer should be dot blot hemorrhages. Important point, earliest feature is microaneurysms, most specific feature is dot blot hemorrhages usually. Okay, so these are your retinal hemorrhages which can be seen, right? These are hard exudates which are seen. Okay, these are your cotton wool spots which are seen. Along with that, you can see venous beadings along with dilatations and segmentations in the veins of your retina, right? So please remember. And now if the abnormal new vessels start developing, then that progresses to a proliferative diabetic retinopathy. PDR में develop होता है, okay? And usually in cases of proliferative diabetic retinopathy, we can see cystoid macular edema. In proliferative diabetic retinopathy, what happens? The middle part of the fundus, that is your macula, okay, it is affected. Edema हो जाता है, extravasation of fluid हो जाता है, and that leads to cystoid macular edema. CM is also seen in cases of NPDR, okay, but it is also seen in cases of PDR. And cystoid macular edema can present as honeycomb appearance or flower petal appearance. It can present as honeycomb or flower petal appearance. Important one. Okay, along with that, in PDR, what happens, as the new vessels are encroaching, these new vessels would pull the retina towards the vitreous, and that can lead to tractional retinal detachment. We have discussed already, and these new vessels can undergo rupture, okay, and that can lead to vitreous hemorrhages. These are usual findings in cases of proliferative diabetic retinopathy. What is the treatment of choice for proliferative diabetic retinopathy? It is this, okay. This image had come earlier. This image is of pan photocoagulation. So please remember what happens. Pan photocoagulation is done in this image, okay. All these spots are seen now. These are due to pan photocoagulation, which is the treatment of choice in cases of proliferative diabetic retinopathy. Moving further to our next one, guys, question number 35. The size of optic disc is, okay, so this is again a fundoscopic image, a normal fundoscopic image, wherein we can see the visible part of the retina, okay, the visible part of the retina, which is known as the fundus, okay, right, visible part of retina, which is known as the fundus. Second is your optic disc, okay. What is optic disc? Optic disc is actually the visible part of your optic nerve head, okay. So the visible part of your optic nerve head is known as your optic disc, okay. And the size of optic disc is how much? The diameter of optic disc is 1.5 mm. The diameter of optic disc is 1.5 millimeters. Option B, right. What is macula? Macula we have discussed multiple times now. Macula is what? The central part of your retina. The central part of retina is known as your macula, okay. And what is the diameter of macula? So please remember, this is your macula somewhere over here, okay. So please remember, this is your macula. Over here they have given this macula, okay. So please remember, macula is the central part of the retina with fovea at the center, okay, with fovea as the center. With fovea as the center. What is the diameter of macula? Macular diameter is 5.5 mm. Macular diameter is 5.5 mm. Important one. And macula is responsible for what? Yes, it is responsible for central vision or tunnel vision, that we have seen already, central or tunnel vision. Next one is your fovea. Fovea, it is 1.5 millimeters in diameter again, okay. And what is fovea? Fovea, it is the center of your macula. Fovea, it is the center of your macula, which is 2 disc diameters, okay, which is 2 disc diameters, that is almost 3 mm temporal to the optic disc, okay. This is your nasal side, this is your temporal side, so it is 3 mm almost lateral from the optic disc, okay. So it is 2 disc diameter or 3 mm temporal to the optic disc. What is the important point to be remembered about fovea? So please remember, at fovea there is sharpest image formation. Sharpest image formation is usually seen at fovea because it contains maximum number of cones. As maximum number of cones are present at fovea, therefore sharpest image formation is seen at fovea. Important. And last, what is foveola? So please remember, the center of fovea is known as foveola. Center of fovea is known as foveola, which is only 0.35 mm in diameter. I hope all the things are clear to you now, okay. So this is your optic disc, 1.5 mm in diameter, that is your optic cup. These are your retinal veins and your retinal artery, okay. So everything is clear to you, I hope so. And let's move further to our next question, that says 36, question number 36. Cattle track appearance is seen in, and options are CRVO, CRAO, CSR, diabetic retinopathy. So now let's discuss about two important diseases. First is CRAO and second is CRVO. Okay, what is CRAO? That is central retinal arterial occlusion. Okay, the central retinal artery, it is occluded. Okay, so it is occluded due to some embolus. Okay, a thrombus which has been dislodged and it blocks now the retinal artery, the central retinal artery. It causes this occlusion. Okay, and it can lead to what? Central retinal arterial occlusion usually presents with a sudden painless, again, okay, sudden painless loss of vision. Okay, so please remember, sudden painless loss of vision is usually seen in cases of central retinal arterial occlusion. This is the symptom, right? With this the patient presents to you. What would be the signs seen? So please remember, there are two important signs that you need to remember. Okay, the two important signs. First, you can see the retina is not as much as red. Okay, the retina is not red. Okay, because the artery is blocked usually. So therefore, you can see a pale retina, or you can see a retinal whitening. You can see retinal whitening. But on this pale or a whitened retina, you can see the spot, okay, a bright red spot. And this bright red spot is known as what? It is known as your cherry red spot. Why is this cherry red spot seen? So please remember, this cherry red spot is usually seen at the level of fovea. यहाँ पे fovea होता है, okay? At the level of fovea, we can see this cherry red spot. Why? Because the ganglion cell layer, as we all know, there are 10 layers of retina. One of the layer is ganglion cell layers. And ganglion cell layer is very much important because it contains all your retinal vessels. Okay, so please remember, this ganglion cell layer, it is usually absent at the fovea. Okay, this ganglion cell layer is usually absent at the fovea, due to which the retina becomes transparent and we can visualize the posterior vascular choroid. We can visualize the posterior vascular choroid. That is why we can see this cherry red spot on a pale or a whitened retina. I hope this is very much clear to you now. Very good, guys. I'm really happy that you are answering these questions. Along with the second sign, guys, which can be seen, what you can see over here, attenuated blood vessels, a thinned out blood vessel is seen, okay, जिसकी वजह से क्या दिख रहा है, segmental blood flow, यहाँ कम दिख रहा है, यहाँ ज़्यादा दिख रहा है, यहाँ कम दिख रहा है, यहाँ ज़्यादा दिख रहा है, okay, and this segmental blood flow is due to this attenuated blood vessels, and these attenuated blood vessels or this segmental blood flow will show which sign? It would show us the cattle tracking sign or the tram track sign. So please remember, they will show us the cattle tracking or the tram track, or sometimes we can say it as railway track or box carrying sign. All of these signs, okay, so please remember, cattle tracking, tram track, railway track or box carrying signs, they are due to the segmental blood flow seen in cases of central retinal arterial occlusion. Important points to be remembered. Now next one is your central retinal venous occlusion. Okay, it is mostly due to a sclerosed retinal artery. It is compressing on the retinal vein, and as this sclerosed retinal artery is compressing the retinal vein is also compressed, and therefore there is congestion of blood inside the retinal venules. Okay, retinal venules are congested with blood, and if these vessels में pressure ज़्यादा बढ़ जाता है, then they would lead to hemorrhages, and these would be flame shaped hemorrhages. Okay, these would be flame shaped hemorrhages, and these flame shaped hemorrhages would lead to what? They would lead to this appearance, and this appearance is known as a splashed tomato appearance. This appearance is known as a splashed tomato or a thunderstorm appearance Okay, so please remember, guys, it is known as a splashed tomato and a thunderstorm appearance seen in cases of CRVO. याद रखना, दो important चीजें हैं, cherry red spot, segmental blood flow, CRAO, splashed tomato, thunderstorm appearance, CRVO. Okay, important. Along with this in CRVO, what we can see neoangiogenesis or neovascularization, and this neovascularization can lead to neovascular or a 100-day glaucoma. This neovascular glaucoma is also known as 100-day glaucoma. Moving further, guys, to our next question, question number 37. True about PHPV. What is true about PHPV? First of all, what is PHPV? All of us know what is PHPV. It is persistent hyperplastic primary vitreous, right? It is what? PHPV is your persistent hyperplastic primary vitreous. So what do we mean by this? So please remember, what do we mean by PHPV? So there is persistence of the hyaloid arteries, there's persistence of the hyaloid vessels and the primary vitreous. Okay, so what happens usually in the intrauterine life or in a fetal eyes? What happens in the fetal eyes, in the posterior chamber, there is a primary vitreous which is there. Okay, there is primary vitreous, and there are these hyaloid vessels which are used for blood supply during the fetal life. But these hyaloid vessels and this primary vitreous, both of these obliterate. Okay, they obliterate after birth. Okay, and after they obliterate, this primary vitreous is replaced by a secondary vitreous which remain throughout life. Okay, इसका मतलब क्या है? The vitreous that we now have in our eyes is actually the secondary vitreous, because the primary vitreous is already obliterated at birth itself, right? So, but in some cases, in some individuals, if these hyaloid vessels and primary vitreous, they persist, okay, they remain, then that can lead to what? Then that can lead to this condition known as persistent hyperplastic primary vitreous. They grow in size also, that leads to hyperplastic primary vitreous. Okay, and these conditions can further cause many diseases, like for example, these patients are more prone to glaucoma, the other patients are more prone to cataract. Okay, so please remember these patients are more prone to cataract or glaucoma usually, right? So now let's see what is the true statement about PHPV. First, visual prognosis is good. No, if these are associated with these many conditions, it can lead to blindness also. So the visual prognosis is not good in PHPV. It is usually unilateral. Yes, this statement can be true. It is usually unilateral, okay. But let's see the other statements too. It is associated with exophthalmos. No, it is not associated with exophthalmos. Please remember this. Option D, associated with microphthalmia. No, yes, it is associated with microphthalmia. So actually this question can have two answers. So it is usually unilateral also, and it is associated with microphthalmia also, right? But the better answer to be chosen over here was associated with microphthalmia, because the association with microphthalmia was seen in many or multiple cases of PHPV, right? Moving further, guys, to our next question that states cause of acute hemorrhagic conjunctivitis. What is the cause of acute hemorrhagic conjunctivitis? And the options are adenovirus, enterovirus, herpes virus, and acanthamoeba. Okay, what is the answer? So please remember, we'll actually talk about acute hemorrhagic conjunctivitis. Okay, conjunctivitis is what? Inflammation of your conjunctiva. Okay, acute matlab kya? It is very painful and the patient is presenting to you in emergency. Hemorrhagic, you can see in this image. Okay, this is acute hemorrhagic conjunctivitis, where the conjunctiva is bright red due to some hemorrhages. Okay, so now, which is the most specific organism which can lead to acute hemorrhagic conjunctivitis? So please remember, the most specific organism leading to acute hemorrhagic conjunctivitis is enterovirus 70. It is enterovirus 70, also known as Apollo virus, So please remember, the most specific organism causing acute hemorrhagic conjunctivitis is enterovirus 70 or Apollo virus. Important. The other viruses which can lead to acute hemorrhagic conjunctivitis, those are picorna virus, adenovirus, Coxsackie virus, and ecoviruses. So please remember, the other viruses which can cause acute hemorrhagic conjunctivitis are picorna, adeno, Coxsackie, and ecoviruses. But the most specific remains enterovirus 70. Next one is your angular conjunctivitis. Angular conjunctivitis में क्या होता है? There is lateral canthus maceration. The lateral canthus is macerated actually. Okay, so lateral canthus maceration occurs in angular conjunctivitis. And which is the most common cause for angular conjunctivitis? This is a question which has been asked from micro also. The most common cause for angular conjunctivitis is Moraxella Axenfeld. The most common cause for angular conjunctivitis is Moraxella Axenfeld. Important point, please remember this. It is Moraxella Axenfeld. And what is the treatment for angular conjunctivitis? It is 1% tetracycline ointment. It is 1% tetracycline ointment which is given. Next, moving further to our next one, which is the most common type of conjunctivitis. These are most important questions that you need to remember about conjunctivitis. The most common type of conjunctivitis. Conjunctivitis can also be viral, it can also be fungal, it can also be amoebic, it can also be bacterial. So which is the most common type of conjunctivitis? Anybody? The most common type of conjunctivitis, please remember, it is viral conjunctivitis. Okay, most common type of conjunctivitis is viral conjunctivitis, and the most common virus leading to conjunctivitis is adenovirus. Most common virus causing conjunctivitis is adenovirus. Which is the most common bacterial cause of conjunctivitis? The most common bacterial conjunctivitis is Staph aureus. The most common cause is Staph aureus again. Okay. And what is membranous conjunctivitis? In membranous conjunctivitis, actually a membrane over the conjunctiva is being formed. Okay, and membranous conjunctivitis, it is usually seen in conditions like adenoviral, diphtheric, and Streptococcus hemolyticus. So please remember, in Strep hemolyticus also we can see membranous conjunctivitis. Usually we know diphtheria, wherever diphtheric infections are seen, there is a membrane associated. Okay. So please remember, in adenoviral, diphtheric, and Streptococcus hemolytic conjunctivitis, we can see membrane. Okay. So the answer over here, the cause of acute hemorrhagic conjunctivitis, the best answer here would be option B. Okay, enterovirus. Okay, enterovirus 70 is the best answer. Yes, adenovirus would have also been right, but the most specific organism is enterovirus 70. Therefore, the best answer would be this. Moving further, guys, now question number 39. What is the best treatment of amblyopia? What do we mean by amblyopia, guys? Amblyopia means lazy eye. ठीक है, आलसी है बहुत. So amblyopia is lazy eye. What is the basic cause of amblyopia? फिर से हमें पता नहीं. That is idiopathic. The most important cause or the most common cause of amblyopia is idiopathic. हमें पता ही नहीं है. Okay, it is just lazy eye. Okay. So what happens in lazy eye? The eye does not accommodate properly. Okay, one of the eye, it does not accommodate properly. This is known as your lazy eye. What is seen in amblyopia? We can see crowding phenomena. What do we mean by crowding phenomena? So please remember, the letters would be read better when they are single. Okay, letters would be read better when they are single. So if I write this WHAT, the patient can read easily. But if I give this word to the patient would not be able to read this word properly. Okay, this is known as your crowding phenomena. Okay, I hope this is clear to you. Now, what is the treatment for amblyopia? The treatment for amblyopia is usually a occlusion trial. Okay, we usually occlude a normal eye. ठीक है, याद रखना, it is not the affected eye which is occluded. Occlusion trial of your normal eye. क्यों? तो if the normal eye is affected, जो lazy eye होती है उस पर stress पड़ता है. Okay, so it becomes disciplined थोड़ा. So occlusion trial of normal eye is given till what age? So till 7 to 8 years of age. Till 7 to 8 years of age, because this is considered to be the amblyogenic period. इसमें amblyopia develop होता है. So till 7 to 8 years of age, till the amblyogenic period, usually we occlude the normal eye to overcome the amblyopia. Okay. So what is the treatment? The best treatment in cases of amblyopia is option A, that is occlusion of the normal eye. Right? Important. Moving further, guys, to our next question. Question number 39, which states, which of the following is a carbonic anhydrase inhibitor used in glaucoma? As we all know, glaucoma, we have discussed raised IOP, optic nerve and visual field defects are seen in cases of glaucoma. Main two types, angle closure and open angle glaucoma, right? Usually for the angle, okay, for actually assessing the angle, whether it is open or not, we usually perform a test known as gonioscopy. This is important. I just want you to know this. So for angle assessment, we usually perform a test known as gonioscopy. Okay, yaad rakhna hai. So which is the carbonic anhydrase inhibitor? Guys, carbonic anhydrase inhibitor, please. So let's discuss first of all about this. Okay, so treatment of glaucoma we will be studying. Okay, treatment of glaucoma, it is very much important. I have already told you, we have studied the surgeries of glaucoma, but they are the last stay of treatment. They are not the preferred options. The first initial treatment options are usually medications in both the cases, acute angle closure or in cases of open angle glaucoma. So in angle closure glaucoma, the first drug which is given is your IV mannitol. Okay, the first drug which is given in cases of angle closure glaucoma is IV mannitol along with glycerol, along with a carbonic anhydrase inhibitor known as acetazolamide tablet. It is an oral drug. Okay, a tablet is given. So please remember, the first drug given in conditions of angle closure glaucoma is IV mannitol. It is given along with glycerol and tablet acetazolamide. Important. But which is the drug of choice for acute attacks? Okay, the drug of choice for acute attacks, when the patient is presenting to you with pain and all these things, okay, the drug of choice for acute attacks would be what? It is your cholinergic drug known as pilocarpine. So please remember, it is pilocarpine. It is a cholinergic drug, therefore it can lead to meiosis, and as it causes meiosis, it can break the attack. It causes meiosis and it can break the attack. This is the mechanism for which pilocarpine is the drug of choice for acute attacks of angle closure glaucoma. Moving further to our next one, which is now talking about the open angle glaucoma. Which is the best drug preferred in cases of open angle glaucoma? The best drug preferred in cases of open angle glaucoma is your, please tell me, it is your prostaglandin analog. Anybody? The prostaglandin analog. Which is the prostaglandin analog which is preferred? So please remember, it is your latanoprost. It is your latanoprost which is the preferred drug. Bimatoprost, okay, trovaprost, latanoprost, all of these drugs are prostaglandin analogs which actually increase the ovuoscleral outflow. which increase the ovuoscleral outflow, right? These are the best drugs used in cases of open angle glaucoma. We can also use beta blockers. Okay, beta blockers, as we all know, like timolol can be used. Okay, timolol, या फिर betaxolol can be used. Okay, betaxolol is important, guys. Why it is important? Because it is a beta 1 selective blocker. Okay, so betaxolol is a beta 1 selective blocker. It does not block the beta 2 receptors, which are usually located on the bronchus. Okay, as it does not block the beta 2 receptors on the bronchus, it does not cause bronchoconstriction, and it is usually safe to be given in cases of asthmatic patients. It is usually safe to be given in cases of asthmatic, where all the other non-specific beta blockers are contraindicated in cases of asthmatic patients or in coronary artery disease also. Right, we can also give a alpha agonist agent. The alpha agonist which is preferred is brimonidine or aplacolomidine. Okay, brimonidine or aplacolonidine, important ones. Okay, pilocarpine can also be given in cases of open angle glaucoma, which is a cholinergic drug, and also we can give carbonic anhydrase inhibitors like acetazolamide, brinzolamide, dorzolamide like drugs. Right, now moving back to our question, which is the carbonic anhydrase inhibitor used in glaucoma? The answer would be option D, acetazolamide. Pilocarpine is cholinergic drug. Okay, latanoprost is a prostaglandin analog, and timolol is a beta blocker. Lol. Right. Moving to our next question, guys. Question number 40. True about dendritic ulcer. We have already seen that dendritic ulcer is what? It is a viral keratitis, right? Viral keratitis, that is inflammation of your cornea again, but due to some viral cause. So the most common virus which is responsible for causing viral keratitis or dendritic ulcer is what? It is your HSV, that is herpes simplex virus. Okay, so herpes simplex virus or HSV is the most common organism or virus leading to keratitis. Okay, HSV. So viral keratitis is usually recurrent. Okay, बार attacks होते हैं. Usually viral keratitis is recurrent and it is associated with decreased corneal sensation. It is associated with decreased corneal sensation. Corneal sensation कम हो जाती है in keratitis, right? Whenever there is inflammation वगैरह. So in HSV or herpes simplex keratitis, we can see this dendritic ulcer. We can see what? We can see this dendritic ulcer. So dendritic ulcer would be something like this, which you can see, okay, with terminal knobs. These are your dendrites with terminal knobs. So this is what is your dendritic ulcer, and this stains green in color on a fluorescein angiography. If we perform a fluorescein angiography, this dendritic ulcer due to herpes simplex virus stains green in color. This was also a question which have been asked. Okay, please remember. And this you can see, it is known as a pseudo-dendritic ulcer because it does not have any terminal knobs. Also it can be known as, it is also known as a geographic ulcer. Okay, it is also known as geographic or a pseudo-dendritic ulcer, which is associated with herpes zoster virus. Okay, please remember, it is associated with herpes zoster virus, pseudo-dendritic ulcer. Okay, important one. Here only dendrites can be seen, no terminal knobs are seen. Right. Next one, guys. Now you need to remember the drug of choice. Please remember this. The drug of choice in cases of herpes simplex virus is a 3% acyclovir ointment. It is 3% acyclovir ointment. Okay, 3% acyclovir ointment. Whereas in cases of herpes zoster virus, the drug of choice would be what? The drug of choice would be oral acyclovir. The drug of choice would be oral acyclovir. Important one. Next is your Acanthamoeba keratitis. Next is your before going to that, let's finish about dendritic ulcer. Which is the true statement about dendritic ulcer? Anybody? Option A, hypopion. Can we see hypopion? No. Hypopion are usually seen in cases of fungal or bacterial keratitis, right? We have discussed it. Second, option B, decreased corneal sensation. Yes, we have said it. Usually corneal sensations are decreased. किससे पता लगेंगे कि corneal sensation decrease हुआ या नहीं? By which method? It was esthesiometry. Remember, it was esthesiometry, right? Increased corneal thickness? No, corneal thickness is usually decreased, and that can lead to perforation also, right? Keratoplasty करेंगे फिर. Okay, important one. Now talking about Acanthamoeba keratitis. What is Acanthamoeba keratitis? It is an amoebic keratitis. The most common organism associated with Acanthamoeba keratitis it is. Please remember, the most common organism associated is Pseudomonas. The most common organism associated is Pseudomonas. But if they ask the most specific organism associated with Acanthamoeba keratitis, naam mein hi hai, right? It is Acanthamoeba. It is Acanthamoeba. Okay. So most common organism causing Acanthamoeba keratitis, the answer is Pseudomonas. Most specific organism, it is Acanthamoeba keratitis. Okay. So Pseudomonas, it is the most common organism responsible for causing keratitis in contact lens users. So yaad rakhna, in contact lens users, the most common organism causing keratitis is Pseudomonas. The most common organism causing keratitis in contact lens users is Pseudomonas. Why I am repeating it? Because this question has been asked. Okay. So contact lens users में जो chronically बहुत लंबे समय तक अगर contact lens use कर रहे हो, so keratitis is usually seen with Pseudomonas. Whereas the most specific organism which causes keratitis in cases of contact lens users is your Acanthamoeba, right? And please remember one important thing about Acanthamoeba keratitis: it is the most painful keratitis. Okay, so please remember, it is the most painful keratitis out of all. And how is Acanthamoeba keratitis treated? Acanthamoeba keratitis is usually treated, I will write over here, Acanthamoeba keratitis is usually treated with polyhexamethylene biguanide, that is PHMB, polyhexamethylene biguanide. Moving further, guys, to our next question. In uveitis, site of keratic precipitates is. Site of keratic precipitates is. Now I'll just wait for your answers because most of the things in these last 10 questions we have discussed already. So just rapidly give the answers, guys. In uveitis, site of keratic precipitate is what? Anterior lens, posterior lens, corneal endothelium or corneal stroma. In the meanwhile, I'll be telling you about this. In uveitis, as we all know information of your uvea, we can see keratic precipitates, which are what? They are these heavy cells which get stuck behind the cornea. Okay, these are your heavy cells which are stuck behind the cornea. Okay, these keratic precipitates. Anteriorly, I have told you, anteriorly they are seen configurated in a triangular fashion, and this triangular fashion configuration of these keratic precipitates anteriorly which is seen is known as what? It is known as your arched triangle. Okay, this is known as your arched triangle, right? Keratic precipitates, either it can be mutton fat keratic precipitates or it can be thin fine keratic precipitates. Mutton fat keratic precipitates are usually seen in cases of granulomatous uveitis, in conditions like sarcoidosis where we can see granulomatous uveitis. Okay, in conditions like granulomatous uveitis we can see mutton fat keratic precipitates, and in non-granulomatous uveitis we can see thin fine keratic precipitates. And this configuration of keratic precipitates in a triangular fashion is known as the arched triangle. The arched triangle, right? Answer is very good, guys. Answer is option C, corneal endothelium. These heavy cells are stuck on the corneal endothelium, right, on the innermost part of or innermost layer of your cornea. Now moving further, guys, to your next one. Which of them is seen in iridocyclitis? Question number 42. Which of them is seen in iridocyclitis? Iridocyclitis is what? Inflammation of your iris along with ciliary body, right? That is a part of anterior uveitis, right? Anterior uveitis ही होता है ना ये. So which of the following findings are seen? We have already discussed this. Option B, that is keratic precipitates are usually seen in cases of iridocyclitis or anterior uveitis. Right, moving further to our next question. Question number 43. Crowding phenomena is seen in. This we have also discussed. Just tell me the answer. Crowding phenomena. What was crowding phenomena? When the letters are read better single, okay, rather than when they are combined. The answer to this question would be, guys, crowding phenomena. Crowding phenomena. So crowding phenomena is usually seen in cases of option A, amblyopia, that is lazy eye. Very good, very good. It is usually seen in cases of amblyopia, lazy eye. Question number 44. Klebsiella pneumoniae causes what? Klebsiella pneumoniae causes option A, chalazion, option B, stye, option C, entropion, option D, keratitis. We have already discussed about keratitis. Most common type of keratitis usually is your viral, okay, and most common viral keratitis is your adenovirus, right? Entropion is inwardly turned eyelids. Okay. Stye is what? Stye is inflammation of your Z's and mold glands. It is acute suppurative inflammation. It is also known as external hordeolum. And stye ka most common cause we have discussed. S for stye, S for staph, or yes. So the answer to this question would be option A, that is chalazion, which was chronic granulomatous inflammation of your meibomian glands, further leading to what? Further leading to a tarsal or a meibomian cyst that is known as chalazion, which is a recurrent condition. Okay, and the treatment is incision and drainage. So please remember, Klebsiella pneumoniae is a very common cause for chalazion. Okay, remember this. Question number 45. Structure with highest refractive index. Which is the structure with highest refractive index? The options are cornea, lens, aqueous humor and vitreous humor. So just remember few points about refraction now. So about refraction, the total power of eyeball कितना होता है, कितने diopters होती है? The total power of eyeball is plus 60 diopters. The total power of eyeball कितना है? Plus 60 diopters, out of which plus 43 diopters is given by the cornea. Plus 43 diopters is given by the cornea, whereas plus 15 to plus 17 diopters is given by the lens, right? Plus 15 to plus 17 diopters is given by the lens. Now talking about the refractive index. Okay, so refractive index usually will study about these. Aqueous humor and vitreous humor have the same refractive index of 1.34. Okay, the refractive index of aqueous and vitreous humor is same, that is 1.34. Okay, cornea का refractive index कितना होता है? 1.37. Okay, corneal refractive index is 1.37 and lens का refractive index is 1.39. Okay, lens का refractive index is 1.39. If we have a better answer, that would be the center of the lens जिसका refractive index होता है 1.42. Okay, if here they would have given center of lens as an option, that would have been the best answer, but as it is not there, so the answer over here would be option B, that is lens. Very right guys, very correct. Okay, moving further to our next question. If the eye has a perforating injury, which area is most susceptible to develop sympathetic ophthalmitis? अगर आई में perforating injury होती है, which of the area is most prone or most susceptible to develop sympathetic ophthalmitis? And we have already discussed this. The most dangerous area of the eye, where if penetrating injury occurs, the infection can spread to whole of the eyeball, mainly to the vascular and the neural coats of the eyeball. That is what the answer to this question is, guys. The answer to this question is option C. Okay, please remember ciliary body. Okay, so please remember any perforating injury to the ciliary body can lead to development of sympathetic ophthalmitis, about which we have already discussed. Yes, very good guys. Moving further to the next question. Microaneurysms are characteristic for which disease? This we have already discussed. Microorganisms are the earliest characteristic feature of what? Microaneurysms are the earliest characteristic feature of which disease? So please tell me. Microaneurysms are the earliest characteristic feature of which disease? They are the earliest characteristic feature of option B, that is diabetic retinopathy. Very good. They are the most characteristic feature of diabetic retinopathy. Moving further to our question number 48. Which of the following is used in acute anterior uveitis? The most important point over here. Just tell me the answers first and then I'll be coming to you again. So I need the answer over here, guys. For this question I can wait. Okay, I can wait for you to answer because I know people usually tend to make mistakes over here. So now tell me which is very good, very good. Very good, Krishna. If you are a student of Delhi Fmg, whenever I come, let me know. You will be receiving a chocolate from me. The last two people also, the last time I promised in my antimicrobial session, please do message me once. Okay, so in cases of acute anterior uveitis, what did I say? If it was only anterior uveitis, the drug of choice was steroids. Okay, eyes closed. But they have already mentioned acute anterior uveitis, where the main or the primary aim is to relieve the pain due to the ciliary muscle spasm. So you need a cycloplegic agent, that is option C, atropine. Okay, atropine like drug. Okay, please remember important point about atropine. It is the longest acting cycloplegic. It is the longest acting cycloplegic, and the shortest acting cycloplegic agent is tropicamide. The shortest acting is tropicamide. Therefore, please remember, as atropine is the longest acting cycloplegic agent, it can cause blurring of vision. Therefore, for any of the fundoscopy or retinoscopic examinations, we cannot prefer atropine in adults. Therefore, tropicamide is usually preferred choice in adults, whereas atropine is a preferred choice in cases of children. Okay, please remember these are the two most important points that you need to know. Half-life of atropine is usually 21 days. This can be asked. Okay, half-life of atropine is usually 21 days. Moving further, guys, now next one, question number 49. Retinal investigation done with the help of a dye is known as what? This is very easy, guys. Option A, fluorescein angiography. Option B, optical coherence tomography. Option C, ultrasound. Option D, visual field. So the answer to this question is option A, fluorescein angiography, and this is the image of fluorescein angiography. So what happens? A dye is injected in the peripheral circulation from usually the antecubital vein. This is a fluorescein dye which is injected from the peripheral circulation, which goes into your retinal vasculature. Okay, and then by a camera you take this fundoscopic picture. Okay, and then you can actually assess the pathology, any of the pathologies in your retinal vasculature or your retinal vessels. Okay, so this is the basic what you can say idea behind fluorescein angiography, right? Next one, this image is what? This image your OCT. This image is your ऑप्टिकल कोहेरेंस टोमोग्राफी. मोस्टली ये इमेज आएगी नहीं, बट एटलीस्ट रिमेंबर द इमेज. ओके, ज़्यादा कुछ नहीं पूछेंगे इसके बारे में. सो इट इज एक्चुअली अ 2D इमेज ऑफ योर retina. So please remember, all the retinal layers can be clearly seen. See, all the retinal layers are clearly seen. All the 10 retinal layers are clearly seen on optical coherence tomography. So the best one is optical coherence tomography to assess all the retinal layers. Okay, ultrasound A scan is usually preferred in assessing the axial length or the anterior posterior length of the eyeball, whereas ultrasound B scan is usually used in cases of posterior segment pathologies. Whenever we need to assess any posterior segment pathologies in the vitreous, in the retina, we usually can prefer a ultrasound B scan. And for visual field, what is the test used? For visual field we use perimetry. Question repeated. What is the test used for visual field examination? For visual field examination, the test used is known as perimetry. And the last question for you guys today is in which disease is collagen cross-linking used? I feel all of you know this by now. We have discussed this already. The answer to this question is option C, keratoconus. Now let's discuss some few points about your keratoconus. What did I tell you? Some conical cornea. Okay, what happens in keratoconus? There is a conical elevation of conical cornea can be seen. Okay, it is usually seen in young males. Okay, conical cornea or keratoconus, it is a common condition which is usually seen in young males. And the common complaint that they have, if a clinical case is presented to you of keratoconus, the main symptom or the main complaint that they will definitely give is repeated change of glass numbers. So please remember, usually the patient complains of repeated change of glass numbers. In the last 6 months there have been repeated changes in the glass number. Okay, which are the important signs that you need to remember, guys? The important signs that you need to remember. Okay, so please remember the important signs of keratoconus that you need to remember are, first of all, Munson sign. Okay, first is your Munson sign. What do we mean by Munson sign? Munson sign is this one. Okay, notching of your eyelid. Okay, notching of eyelid when you look downwards. Okay, on down gaze, when the eyelids notches due to this conical cornea, this is known as your Munson sign. Next are your two reflexes. Important, remember the name at least. Oil droplet or scissoring reflex. Two important reflexes seen are oil droplet reflex or scissoring reflex. Then you can see one important phenomena, that is Fleischer ring. What is Fleischer ring? So please remember, Fleischer ring is due to iron deposition. So please remember, if iron deposition occurs on the epithelium of the cornea, then you can see this Fleischer ring. Okay, iron deposition on the head of the pterygium was leading to Stocker's line, and iron deposition on the epithelium of cornea is leading to Fleischer ring. Yaad rakhna. And we can see some vertical stress lines known as Vogt striae. Okay, Vogt striae are what? They are your vertical stress lines seen on the descendants membrane of cornea. They are usually seen on the descendants membrane of cornea, right? Most common symptom we have already discussed, that is repeated change in glass numbers. Repeated change in glass numbers important है, बहुत याद रखना ये. Okay, repeated change in glass numbers. And lastly, what is the treatment of choice? The treatment of choice is C3R, that is collagen cross linkage along with riboflavin drops. Okay, we perform a collagen cross linkage along with riboflavin, that is vitamin B2 drops are given. Okay, riboflavin drops. And we can also perform a LASIK surgery, but when the patient is more than 18 years of age. LASIK less than 18 years of age, in cases of keratoconus it is usually contraindicated, right? It is usually contraindicated in cases of keratoconus. It is usually contraindicated. LASIK is absolutely contraindicated in cases of keratoconus. Okay, and it is also contraindicated if the patient is less than 18 years of age. I hope things were clear to you guys. Thank you so much for this session, for being attentive throughout. I hope this has helped you revising your ophthalmology. These were the most important few points that had come in the previous year examinations. I will be coming up with a clinical case discussion very soon in an integrated fashion, okay, with my colleagues, and there will be discussing some important points that we might have left, okay, in this session. And I hope this session was fruitful for all of you. Thank you so much for attending, and my pleasure guys. Thank you so much. My pleasure.